Recording in progress.
Thanks, Andy. Hi, everybody. Welcome to the fiscal year 2020 EMS Supplement Small Group Meeting. We did this last year, so I guess we can call this our second annual. Our agenda today is pretty similar to what we did last year, except for we added in some discussion of outcomes and sustainability. So that will happen a little bit later. So I am going to turn it over to Tahleah if you have something you wanted to say really quick, and then after that we'll introduce ourselves.
Sure, great, thanks Nicole. So hi everybody, nice to see you all. I'm really looking forward to today's meeting, not only for for myself, but for all of you to really get the chance to hear a bit more about the other supplement projects and what's been going on. I would also just like to take a moment to say thank you to all of you for your patience, for your help, as I've been getting up to speed on your projects and the different processes and how everything works, just to get up to speed on all of them. It's hard for me to believe, but my 1-year anniversary of joining FORHP is actually next week. And there's certainly plenty more for me to learn, but I just want to extend my appreciation and my thanks to all of you for helping me along the way. And I look forward to continuing, our work and our progress with EMS. So I'm going to turn it back over to Nicole.
Thank you, Tahleah. So we're going to just go around and introduce ourselves. I'll call on you, and what I want you to do is just name and state. I feel like we name, state, and role. So if you're the Flex coordinator or the Flex project director or a consultant to the project, that would be helpful to know. Our keynote speaker, Shawn Baird, is in the room, and I will introduce him fully, but he doesn't know, I'm guessing, most of you. So it would be helpful, especially for him, to know name, state, and role. And then also I'm going to ask you a question. I promise it won't be a hard question. You only really get 2 answers, so it'll be pretty simple. So let's start with John Noakes.
If I can get on the right screen to unmute myself, it works a lot easier. So my name is John Noakes. I am with Washington State Department of Health, and I am the Rural EMS Coordinator for this project.
So John, my question to you is, would you rather have your own robot or a jetpack?
I have a drone. I like seeing stuff from the air, so I think I'd rather have a jetpack.
All right, sounds good. Thanks, John. Next is Jody Ward, and then after Jody Ward, it will be Martina and Sarah. So Jody, name, state, and role, and then I'll ask you a question.
Okay, so Jody Ward, I'm Program Director for our Medicare Rural Hospital Flexibility Program, and we also host a Critical Access Hospital Quality Network.
Great. Would you rather never be stuck in traffic again or never get another cold?
Ooh, never get another cold.
I don't know, traffic's pretty annoying. All right, thank you. Martina, and then Sarah, and then Joyce.
Hi, I'm Martina Garcia. I'm the Flex Ship Coordinator of New Mexico Office of Primary Care and Rural Health.
Okay, and would you rather have a rewind button or a pause button for your life?
Probably a rewind button.
Thank you. Sarah Contraster from the Flex Monitoring Team.
Hey, I'm Sarah Contraster. I'm with the Flex Monitoring Team. I'm with the University of Southern Maine.
All right, and would you rather speak to animals or know other people's thoughts?
Speak to animals.
Yeah, thank you. And next is Caleb, and then Jane.
Oh, then you want me?
Oh, I'm sorry. Yes, go ahead, Joyce.
Joyce here, Center for Rural Health here at the University of Arizona, Melanie Zuckerman College of Public Health. My title is Senior Advisor, Rural Programs, and provide support on a variety of projects at the center. So subbing here for Eileen Hardcastle.
Yeah, and she's your project consultant. So that is who we hear from quite a bit, but she couldn't be with us today. So my question for you is, would you rather know all the mysteries of the universe or know the outcome of every choice you make?
Oh, universe. Yeah.
Thank you. Caleb.
My name's Caleb Williams. I work for the Kentucky Office of Rural Health, and I am the project manager for Committed to the Heart.
Would you rather have a pet skunk that sprayed you once a month or a pet porcupine that quilled you once a month?
Probably the porcupine. Yeah.
I kind of have a hard time with that one, but I think that one would be my option too. Thank you, Caleb. Jane Bedford.
Good morning or afternoon. My name is Jane Bedford. I'm the Rural EMS Coordinator for the state of Florida.
Jane, would you rather be able to shrink down to the size of an ant or grow to the size of a skyscraper?
Probably the ant.
Yeah, thank you. John Gale.
Yes. John Gale, I'm from the Flex monitoring team at the University of Southern Maine, and I'm one of the evaluators.
Okay. And my question for you is, would you rather have a permanent splinter under your big toenail or have a permanent bad haircut?
I'll take the splinter.
Me too, I think.
Although I probably have both.
Thank you, John. Kayla, and then Daniel, and then Britton.
Yes, it's Kayla Combs. I'm with the Kentucky Office of Rural Health. I'm a rural project manager and flex coordinator there. I also have Scott here with me, so I'll answer my question and then I'll let Scott introduce himself.
Sounds good. Would you rather go on a roller coaster or go skydiving?
Oh, roller coaster, no question. Yeah.
Thank you, Kayla. Scott?
Scott Helly, rural project manager. I'm still trying to get used to that title, just got promoted. I handle all the EMS projects here with the office.
Congratulations on your promotion. So would you rather always hit a red light for the rest of your life or always get slow internet after the sun goes down?
I think I'd rather deal with the red lights than the slow internet.
Oh, yeah, I mean, imagine watching Netflix and your internet is slow, right? And you're off time. Thank you. Daniel and then Britton.
Hi, can you hear me?
Yeah.
Okay. Sorry, my internet's really spotty today. My name is Daniel Prokop. I'm with the Ohio State Office of Rural Health. I'm the Flex and Ship Coordinator.
Okay, and would you rather be able to fly or be able to teleport?
Oh, teleport.
Yeah. Thank you. Britton?
I'm Britton Herbert with a program manager with the South Carolina Office of Rural Health.
Okay. And would you rather your only mode of transportation be a donkey or a giraffe?
Giraffe. Sure.
Thank you. Donnie in New Mexico, and then Crystal and Abby.
I'm ready. Donnie Roberts, I'm the Director of EMS Regions 1 and 3, and also a paramedic for the military out at a military range.
Okay. Donnie, would you rather be transported permanently 500 years into the future or 500 years into the past?
I would go 500 into the past.
All right, thank you. Crystal and then Abby.
Sure. Good morning, everybody. Crystal Begay over here in New Mexico, Program Manager of the Office of Primary Care and Rural Health.
All right, your question is, would you rather only be able to whisper or only be able to shout?
Maybe whisper. I already do that. I already do that anyway, kind of whisper. I have a soft voice.
Yeah. Can you imagine like all the time everything you say comes out at like volume level 10?
Right.
Gosh, yeah, thank you. Abby and then Lindy.
Hi, I'm Abby Parmenter. I'm the Flex Coordinator with the Florida Department of Health.
All right, your question is, would you rather work at Disney World or at Apple headquarters?
Apple.
Yeah?
Yeah.
I wasn't sure. All right, thank you. Lindy.
I'm Lindy Vincent from the Washington State Rural Health, and I manage both the Flex and the EMS and the SHIP grants.
Great. Lindy, would you rather have a huge imagination or a photographic memory?
Huge imagination.
Yeah, all right. Okay, before I move on to TASC staff and Tahleah, and I suppose I could answer one myself. Did I miss anybody from a Flex program for one of the states? Okay. Andy, introduce yourself, please.
Hey everyone, my name is Andy Naslin. I'm with the National Rural Health Resource Center as a program coordinator with the TASC team.
All right. Andy, would you rather be an only child or have 10 siblings?
Oh, 10 siblings. I have 4. I'm not giving those up.
You're already used to that anyways, right?
Oh, yeah.
I mean, 4 or 10, what's the difference, right?
Exactly.
Yeah, okay. Tracy?
Hi, I'm Tracy Morton. I'm the Director of Population Health at the center, and I'm the program manager for TASC, and I work with Nicole and Andy.
Tracy, your question is, would you rather have to speak in rhyme for the rest of your life or speak in riddles for the rest of your life?
I think I'd go with rhyme. I think people have a hard enough time sometimes understanding me, so I think rhyme would be better.
All right, Tahleah.
Hi there. So I'm Tahleah Chappel. I'm program officer with FORHP, and I have a special focus on EMS.
Tahleah, would you rather go into the past and meet your ancestors or go into the future and meet your descendants?
I think the future.
The future? Yeah, that'd be kind of neat, wouldn't it? All right. You guys all know me. I'm Nicole Clement, program specialist at the National Rural Health Resource Center. I work 100% of the time on TASC and the majority of my time on EMS specifically, although definitely other and all rural healthcare topics end up coming across my screen at some point. So let's see, what should I answer? Would I rather always hit every red light at a stoplight or get a flat tire once a month? Oh, I guess the red light because I don't know how to change a tire, although I bet I would learn really quick if I needed to, and like driving and road rage and like that's reality for me. So I don't know, that's a hard one. I can't even pick. So I'm going to cheat and I'm not going to pick.
But it could be 50 below and changing a tire. Forget it.
Yeah, nasty, right? And then like stopping at every red light.
Yeah.
You'd have to add like a half hour to your travel time to get anywhere. So, oh, I just don't know. I'll have to think about that one some more. So, with that, we are going to introduce our speaker. So our speaker is Shawn Baird, and Shawn has been in EMS for just over 30 years. He became a licensed paramedic in 1990, working in rural Oregon. He has always had a passion for bringing healthcare to underserved populations. As the owner of Woodburn Ambulance for 25 years, he expanded advanced life support services to over 500 square mile area, and is now Chief Operating Officer for the Metro West Ambulance family of companies, overseeing 9 small services stretching from Crescent City, California to Yakima, Washington. He is also the current president of the American Ambulance Association and just completed 2 terms on the National Highway Traffic Safety Administration, or NHTSA's National EMS Advisory Council, otherwise known as NEMSAC. So with that, Shawn, I will turn it over to you.
Great, thank you. And it looks like I dodged a bullet with no question, so I appreciate that. I am going to see if I can successfully share screen to my.
As you get your presentation up and ready to share, Andy has gone ahead and launched some pre-event questions. These are not just our keynote speaker, but for our whole event. So if you guys would just take a minute to answer those while Shawn gets started, that would be great. You can go ahead, Shawn.
And are you seeing these now?
Yes, I do see your presentation.
Great. Okay. Well, I have prepared a few remarks on different things related to the challenges and opportunities for rural EMS specific to COVID. And I'm going to try to tie it the best I can to the work you all do with your state offices of rural health and the Flex program. But I'm going to be completely forthright in saying that I'm not obviously as intimately familiar with the bounds within which you work. And so when we get to the end and start really having discussion and questions and things, I'll be curious to learn a lot about how your program works too, because I think some of the ideas that I'll be presenting, there's some good overlap and some things that I hope I can bring back to the EMS community out of our discussion this morning, as well as leave you all with a few thoughts. So, you know, while it goes without saying that the last year and a half has been, whatever word you want to use, unprecedented, overwhelming, challenging, terrifying at times, all kinds of different ways to express it. One that is particular to EMS is opportunity. We have seen a tremendous amount of growth, both by individual licensed responders, as well as services, individual agencies, whether they be small volunteer ones to big national companies, and the systems of healthcare delivery that they work within. So I think there are some really positive steps that we can take out of what we've been going through together in the last year. Some things were about the same everywhere, and whether that is rural, urban, small system, large system, volunteer paid, we all faced a lot of the same challenges. The initial PPP, why do I always say, I mix those two up because I'm trying to work on PPP loans for a bunch of our agencies, so I apologize. But the personal protective equipment supply issues that left us all scrambling and trying to figure out not just what was appropriate to where and what was indicated or not indicated, but where would we get it? How would it be delivered? A lot of lack of information and lack of unified command and control in the early months. Who's really in charge here? Is this a federal response? Is this a state or local? And many of those things, to be quite frank, are still being worked out today. However, we're certainly much further along than we were 18 months ago. It brought forward what has been a long-standing question. Is EMS public safety? Is EMS medicine? Is it public health? As EMS providers, I like to think of us as, on a good day, we're kind of at the intersection of all of those different disciplines, where they come together and we're sort of a common point and drawing off of each and giving back to each. On a less good day, it's like we're in the fishbowl in the middle of all of those, and everyone is staring in, trying to figure out, well, what are you going to do to jump out and help me? And not really taking into consideration that we have sort of a split responsibility there. That contributes to a lot of stress on the system when it's unclear which role we're really fulfilling. That can be staff stress. Trying to respond to many masters is never an easy role to be in. And then you couple it with the unknown of a new disease. We don't know what we need to do to prevent getting it or bringing it back to our families, et cetera. So these challenges crossed all lines. Financial distress is an interesting one for a couple of reasons. In the early hard-hit areas of the country where activity just went through the roof with EMS, like Yonkers, New York, for example, where Empress EMS was just run ragged. running call after call after call, you would think, oh, well, they must have, at least they are generating revenue, where other parts of the country, all activity stopped. People quit calling 911, hospitals shut down their elective procedures, there weren't inter-facility transports happening, skilled nursing facilities kind of went into lockdown mode, so no one came or went. A lot of things moved to on the phone, or people just forego getting care. EMS is paid by volume, so in a lot of areas of the country, they took a huge financial hit from not being able to bill per call when there were no calls coming in, and at the same time, the heavy hit areas were like Yonkers, New York, were treating people at home or not transporting them or taking them to an alternate destination, none of which would normally be paid by the typical payers of an ambulance bill, either private insurance or Medicare or Medicaid. So they bore, regardless of whether you were on the side of the balance of not enough calls or too many, both caused a lot of financial distress and stress on the EMS systems. And then you had a worried public, regardless of where you were in the nation. Our PSAPs, that public safety answering points where 911 calls come in, had a lot of calls coming in for information. They had to figure out new roles of how to triage and how to appropriately alert responding EMS providers as to the nature of a call and whether or not they should be taking or exercising particular caution. So a large number of stress factors on this industry and segment of healthcare. That being said, even though a lot of things were felt similarly across the nation, things were quite different depending on where you are. As I mentioned before, volume really dropped markedly in many parts of the country, particularly more rural and suburban services just saw calls virtually stop in the early months. At the same time, it was busy in urban areas. Access to PPE was rolled out very differently. It depended on the type of service you were. So if you were a public service, you might have access to things through certain state supply chains or county supply chains that private services may not have had access to. On the flip side, some private services were able to scramble and didn't have to use purchasing procedures that might be barriers in a public entity to just going out on the gray market even and buying equipment. So regardless of the nature of the organization, there were pretty significant impacts there. Funding to make up for the shortfall really varies depending on organizational type. Private services don't have access to direct reimbursement from FEMA, for example. So if they stood up extra crews or deployed to do medical standby at large events, that needed to be figured out how that was going to be funded outside of the process that typically when a government entity like a fire department run ambulance or volunteer third service governmental ambulance would go, and they just keep track of it because it's an emergency. They submit it through FEMA and be able to get some reimbursement for their cost. So a lot of things really, it depended on exactly where you were on the ground during this emergency, how the operational pieces were rolling out. In the photo here, the gentleman, the paramedic that's pictured, that was a photo for a press release back in, that would have been late April of right after the first couple months of this. And we had been running so low on PPE that word got back to someone at the local Home Depot distribution center, and they happened to have a shipment coming through with these P100 masks and donated several cases of them. And I heard stories about that all over the country where it really came down to kind of word of mouth, or people had a family connection or a business connection to someone, and somehow these things just fell into place to the best they could to at least supplement in the early couple of months of how PPE was distributed. Despite all of those challenges, of which clearly there were many, I really feel like EMS absolutely rose to the occasion. We did what we do, which is when there's an emergency, we step up and respond. Took on significant new roles, messaging right out of the gate. We are a trusted source of information in most communities, particularly in very small, very remote communities where oftentimes EMS responders are community members who are volunteers who've taken it upon themselves to get the training they need. And maybe even there's a few paid folks, but by and large, they're very ingrained in the community. And so when clearer information began to come out of CDC and state and local health departments, local EMS agencies really became a very good, reliable source of information for many communities around the country, and started to take on things like mask distribution or other forms of communication about proper hand washing, social distancing. All of those things were tasks that EMS was well suited to, being out in the community and typically by very trusted members of the community. Early on, as testing finally became available and began to be rolling out, and the test and trace programs in the nation were beginning to be implemented, we started to see access by EMS to both rapid testing with, for example, the Abbott ID Now rapid test, or the Binax Now, which is the cards. Those were rolled out and through states and local health departments given to EMS, initially helping to target making sure that the emergency responder community was safe. So having an ambulance service have access to a rapid test meant that EMS, fire, police, health workers within a community, particularly again, rural communities where there may not be access to labs up, in the same way that an urban environment would have. Some of that rapid testing became a good way to make sure that frontline workers were hopefully identified and cleared out of the workforce if they came up positive. And then we began to work on doing other targeted population testing, particularly when it became clear that in different states, every resident of a skilled nursing facility needed to be tested with a PCR test. And so EMS agencies were a natural for getting out into harder to reach communities. Again, urban areas have such a concentration of different ancillary health services available that it's really as you get out into the suburban and more rural environments where being a mobile healthcare professional is just such a different thing, and on a scale that's very different to even like home health nursing or some of those other seemingly related professions, but actually quite different in the sense of we're 24/7. We're used to being just sent here and there, whatever. We don't have a particular patient we're following all the time. So it was a natural. There were things that needed to be learned in order to pull off that testing. We're not normally lab technicians. I mean, it's one thing to do a blood glucose stick on a 911 call. It's a different level to be using equipment like the Abbott ID Now that requires a certain handling and temperature constraints and free from dust, all sorts of issues that we had an education curve ourselves to really work through on the procedure side to make sure we were doing it appropriately. And on the paperwork side for documentation, that's again another level when you start working with the PCR tests, which were often initially at least going to state public health laboratories, and they have a very, very particular process to make sure that, you know, the sample is documented appropriately, that there's absolutely no mistaking who it goes for. I can remember in the early days being involved in some PCR testing where we were going door to door for farm workers, migrant farm workers out in some very rural areas in what would really be considered probably substandard living environments. Pouring rain and trying to write on the vial that the specimen was going to go into and on the form, and it had to have 3 different matching sets of identifiers. And you're talking to people who don't have identification, and then you get a smudge on a letter, and suddenly we would get a call back the next day that they had to throw away the sample because they could not positively identify and match, because of a smudge on the vial, a letter in someone's name from the form to the specimen sample. So these were lessons that EMS is not used to dealing with that degree of specificity. We tend to be like taking more of a care approach of, you know, the shotgun approach of a little bit of everything all over and see what works, and, you know, stop the bleeding, keep an airway open, move fast, etc. So I think that over time, those procedures were cranked down and figured out. And that was a very good, it worked out well, that working through that process in the testing was a good lead up to working through that process when a vaccine became available, because we had sort of conditioned our emergency medical responders to a slightly different environment where we were dealing more with public health and less with emergency department type procedures. So when the vaccine rolled out, we often I heard from many places around the country where those relationships that were developed with local public health departments on testing rolled naturally into relationships to participate in vaccination, and followed the exact same stages where initially it was vaccination among the emergency response community, and then to targeted vulnerable populations as the vaccine became more and more available, and those bubbles would open up to the point of doing large mass testing events. Many EMS agencies by that point were well enough versed to just host their own mass testing event, getting the vaccine through the state health department and reporting it all the way on through. Even some very small, I've talked with several very small volunteer EMS agencies that had, at the most one paid person and then several volunteer folks who went through the effort to become vaccine, credentialed vaccine providers in their state, which is a fair amount of work, and the state figured out ways to expedite it, but still required learning new systems, getting equipment for the appropriate storage and handling, record keeping, access to online vaccination databases that states utilize for providers, et cetera. So some of these very small, very, very rural areas were able to get that all set up and then became the center for their community and surrounding communities for folks to come and get a vaccine. And then ultimately, that tied together with the traditional services that were being offered with ambulance transport, wheelchair transport, et cetera, for COVID positive as well as the general population. I'll just take a flip back at those photos up on the top left there. That's a crew out at a agricultural processing site in the middle of the night. And because those are 24/7 operations with a largely moving population that works at them, a lot of migrant folks, our local public health department in this case had got to EMS because we're used to having crews out in the middle of the night deploying, and they spent many nights in June and July last year all night long going out and doing targeted testing at some of these facilities. And then that same model was later done with vaccination. And then down on the lower left, it's a little hard to see, but that's a bilingual note taped on someone's door. And that's an example of having worked with some local community-based organizations, that a local EMS department actually would target large apartment complexes and other areas and go door to door, offering testing and vaccination at a person's home right then and there, which is a model that we're actually picking up quite a bit more now with vaccine. Early on, it was testing. So as I mentioned, how do you pull all that off? Well, you have to be action oriented. I think that this required a bit of a leap of faith by a lot of folks to say, yeah, I trust that my emergency responders are competent, thoughtful, and they're going to want to do the right thing. So medical directors and state officials were able to take a bit of a jump and issue a lot of very rapidly done temporary scope of practice changes, et cetera, to enable the largest workforce possible to mobilize on this emergency. A key to that is communicating with each other. So all those stakeholders, whether it's state public health officials, local county officials, hospital systems, they need to understand what EMS is capable of on a normal, everyday basis for them to be able to respond to us and move quickly on this. So I think that's a challenge that is still very present. I'm always shocked when we're at a vaccine event or something, or I hear from somebody else in a different part of the country that they were doing vaccination somewhere, and a nurse or a doctor or someone who identifies themselves as a hospital administrator will go through the event and find out that the person is an EMT, and they'll be like, well, I didn't know you guys could even give shots. So there is a huge disconnect still out there about the capabilities of EMS systems. And I think that's a challenge for all of us, just on a continual basis, to make sure that the role and capability of EMS is understood. Collaboration is the answer to so many things. And I say go big and also go local. And by that, I mean, we need to continually engage even our federal partners in figuring out solutions to problems like the PPE distribution, but we need to be very local in the sense of back to that trusted community member medical provider status that EMRs have in many rural areas. Working with other community-based organizations can do amazing things, whether that's partnering with farm worker advocates or the Rotary Club, you know, from one end of a spectrum to the other. That is how you begin to access people. And as we have shifted our national strategy from mass vaccination to really trying to reach individuals and understanding that there's a level of effort to get each and every vaccine into an arm from here forward. I think that EMS partnering with local community-based organizations is going to be an incredibly powerful tool to reach those individuals. And then I put on here a little bit facetiously, joining multiple somewhat redundant work groups. I think I wouldn't need to tell you guys how many times you feel like you're sitting in the same meeting 4 or 5 times a day, talking about the same things with just a slightly different mix of folks. You know, half of them were in the last meeting, but half of them weren't. Eventually those messages all get through and we do get lined up. So it is worth the effort. Most recently, we continue to, I think, see more and more EMS folks engaged on activities around the public health emergency. I've looked at a lot of different payment models of how this is done, and I think the one that that I keep falling back on as kind of the answer, particularly in rural areas, is the concept of buying the medics, the EMT, the vehicle and the infrastructure that's behind them, that being their dispatch center and their toolbox that they carry around. Buying that time and then having the flexibility for how it gets deployed seems to get the most bang for the buck, as we've seen different states use CARES money, for example, to pay for different things. An EMT with a vehicle to get around and their basic toolkit can do an awful lot. They can, if they have a wheelchair van that they're driving around or an ambulance that can be used like a wheelchair or transportation, they can take people to the hospital if they need to. They can certainly take people to their doctor's office to get a vaccine if they're not really comfortable getting it anywhere else. They can deliver the vaccine to that person in their home. They can do all of the testing at home if they want, or they can do well visits, welfare checks on folks who maybe at home have been under a quarantine period and live alone and are of a vulnerable status and need someone to come in and take a visit. Paying per encounter is always very, very difficult to figure out how much should that cost. You know, do I charge $300 to go to someone's house, or do I, or is it 600 or is it 100? Paying for the time and the exclusive use of a 6 or 8 or 5 hour block of time kind of gets rid of all that, because they can be deployed at whatever is most important during that day, and you can work with your local county health department or health system to figure that out. So I just wanted to throw that out there for modeling. Things that are continuing to grow that this feeds into are hospital at home programs, where we have community paramedic and MIH visits that have been expanded to include patients who are admitted to hospital at home but under COVID diagnosis. Those, again, there are certain models around the country. We do one in Oregon. You know, Matt Zavadsky, who I know has spoken with this group before, does a lot in Fort Worth. And there are others. All of those are a little bit difficult to replicate in very rural areas because of the low patient census means that that it becomes very expensive. So I think developing developing models where it's about buying a paramedic for 1 day a week from that service might actually prove to be a little bit better than trying to figure out how to do it on a per patient fee-for-service type model. The regulatory environment continues to change. We've had payment for treatment in place by Medicare approved if a regional protocol existed specific to COVID to treat them at home. There has been a lot of talk about that should be made permanent, et cetera. I think within the industry, we want to do that in a very thoughtful, cautious manner because we want to see how the data really proves out before we jump fully in on that as a permanent thing. Alternative destination, again, a great move forward to be able to take someone to an appropriate urgent care center or something other than an ED. And then there have been many states have used some of their federal money to at least temporarily increase the Medicaid ambulance rate. And then lastly, this group would be very interested to know, there's still $8 billion in the Provider Relief Fund targeted for rural, which is unspent. And at the AAA, we're continuing to push for them to get that allocated out. Going forward, I guess I know I'm running out of time, but we think that the skill set that was developed by both individuals and agencies over this last year is one that will be put to good use. It showed our flexibility and our capacity. I think that one of the drawbacks of all of that is that many other employers saw what EMTs and paramedics can do and have started hiring them away at rates that, particularly in rural areas, you just can't compete with. So it is both a great thing to see that EMTs and paramedics are finally being recognized for what they can do, but unfortunately that will put even more pressure on small communities when maybe they only had 10 or 15 paramedics working in a community of 20,000 and a nearby larger town, a health or hospital system decides, oh, those EMTs can do a lot, let's hire them and put them in the hospital and they can pay twice the wage. So there's going to be, I think we should all be just very aware that there's going to be even more pressure on the system for keeping trained people in smaller communities. What can we do about it? I actually think that, talking with Nicole a little bit, I think that some of the things that need to be done that aren't yet being done in a more formal way are memorializing all of what's happened in the last year, really collating it, collecting it as outside observed data, having not just industry fluff pieces that we publish about ourselves, but having some gravitas to collecting information about all of the different innovative things that have happened would be great. To the extent possible, actually real data of how many vaccinations, like looking at the, in many states that use the alert system, for example, for vaccine tracking, is it possible to find out how many of the vaccines were given by EMS providers? These are questions that will help, if we can answer them, will help build our case for broadening things out, describing different models of innovation, and then that could lead to the publishing of toolkits. Something as simple as how do I become an approved vaccination site or agency? What are the steps that are kind of common nationwide to have to do that through state health departments? What do state public health labs typically require? How could we have little training kits put together to distribute and share so that the next go round of whatever it is, we've got some information that we can put out there that's real nuts and bolts to help them move ahead. And I guess I had one last thought, which is basically with you all, I put that shot up there of all the instrumentation in the plane on the way to Yakima, because I think that's all the data that you need to drive us forward. We need data. That's how we're going to get there. And we need folks who can start to collate that and understand it. And that is what is going to get us over the horizon and moving forward. So with that, I guess I'd leave it open to some questions. I know I used up most of the time, I think, but.
Yeah, you actually have plenty of time still, lots of time for questions and answers. And I see John Noak's camera came back on, so I'm wondering if you have a question or a comment.
Well, I just turned back on because we were at that point again, but I do kind of have a comment. One of the things we looked at in our project originally was cross training. So we talked about the hospital snatching up our EMS providers and causing challenges. And I know we talked about the demographic size, and I'm very familiar with Yakima because that's where I've spent my last 20 years. And those are much larger communities. And the agencies we enrolled in our project are the smallest of the small. But we had hoped to do some cross training. So maybe you train them into an MA or possibly even a CNA, where now they have other healthcare specialties and those people stay in the communities instead of traveling away or moving away. And so you have that great opportunity. The challenge is you have to have small communities that have other healthcare services within them. So the town I live in, that would be a very viable option. But most of our agencies we enrolled they don't have other healthcare facilities. They don't have nursing homes. Most of them don't even have schools within their own districts, which has created a challenge, but I think it's still a viable option in those slightly larger communities.
Yeah, I think your comment is spot on that really for the most remote of the remote, it's going to be about finding a way to have a person that can really wear 4 or 5 hats, somehow hopefully tying them all around the health of the community. So that, it's almost like back to the early days when you do a village health worker or community health worker in remote Alaska, for example, where you really identify folks and maybe they're employed in something that doesn't seem like an obvious fit, but can support it if there's if there's only 1 or 2 positions in a municipality or in a county government that can give them some degree of flexibility with their time so they can leave to respond on an emergency call. I'm talking about areas where there might only be 5 in a month or 2 in a month. I mean, you just don't know. But it's that cross-training flexibility, and then finding it's basically multiple streams of funding come together to pay for it.
Absolutely. Just so you're aware, one of my agencies, they run an average of 12 to 24 calls per year. That's a transporting service.
We did an interesting project that I worked on a few years ago where the U.S. Forest Service and BLM agreed to let a bunch of their field staff get EMR training. And the ambulance service that was 45 miles away or something, but would be responding out to those areas, actually paid for the class to be done remotely. In order to be able to have a pool of first responders there who could at least stabilize the patient and have a handful of tools available. And I think that kind of partnership and innovation is going to be key. Any other?
Yeah, any other questions for Shawn? I have one, which I apologize if you talked about this, but I don't think I heard it. The waivers and flexibilities, expanded scope, and that stuff that has flowed down from the feds during all of this. What do you anticipate, or, you know, this, like I said, when we talked, there's a little bit of crystal balling here, and I'm certainly not saying Shawn is telling us this will happen, but if you had to predict, what do you think might stick around after the public health emergency?
Well, I think that quite a bit of it will find a sticking point. I think it might be a little bit of an ebb and come back. I think that treatment in place, for example, I think what we'll see is probably it will run its course from what the legislation that was passed. Once the public health emergency is no longer in place, that will expire. But fortunately, that's probably not, you know, fortunately or unfortunately, I think we'll be under a declaration for some time to come. So those will continue, and we will be doing simultaneously a different effort by CMS to do cost data collection from ambulance services all over the country, which has been delayed, but finally kind of getting back on its legs. And I think we're going to need to see a dovetail of these different data sets. We'll be able to look back at treatment in place during the emergency. We'll have new cost data coming in, and we will be able to go back to the feds and Congress really with better armed with a complete set of information, and that will be an opportunity going forward that I think will probably in some way come back around. But I don't think it will be a straight extension of what's there, and that's, again, crystal ball, who knows, right?
Yeah.
Alternative destinations probably will stick around. I think that there are many communities where it will be found that there are better, more efficient ways. If you're way out in the far outer reaches and it's a 3-hour transport to get to a hospital, and yet there's a clinic that has capability to treat certain patients within a certain triage scheme, I think that's going to be deemed appropriate, and we're going to see more of that. I certainly think the telehealth, telemedicine component is going to grow even well beyond what we're seeing today. Probably won't look like ET3, which you guys are probably familiar with the model project going on, because there are just too many very specific details in there that made it very hard for rural communities to access that program. But the coincidence of that happening and then the public health emergency overlapping has absolutely put the pressure on to continue to figure out ways to deliver EMS in an alternate fashion. Mm-hmm. And I think that some recognition of directly paying EMS providers to do public health activities is going to stick around for a long time. I could certainly see the vaccine, local public health departments that receive federal money to give flu shots or just receive the vaccine and then can pass that on to their EMS agency to provide the flu shot. They'll either be willing to pay for the crew time to do it, or the crew's billing office can, well, they won't bill for the vaccine because that might be provided at no charge to them. They will bill an administration fee to patients' insurance or whatever. And I think that some of those kind of immunization activities will go on, and we've really laid the ground for it. I've heard of other academic institutions around the country are looking at studying how to use EMS providers even to get to very remote areas, routine childhood vaccinations. If there's a county where it's very difficult for parents to get their kids in to get vaccinated, but they would do it if it came to them. That's a game changer, and we're proving the safety and efficacy of doing that. And I think that will be a long-term win.
Mhm. Yeah, I think the data collection initiative, the ground data collection initiative is really an opportunity. And I feel like it kind of shows that at the federal level, they are thinking about what can we do differently with ambulance services. So I hope that ambulance services are viewing it that way and not just as, you know, something that's going to be arduous and hard. And it is going to be hard. You know, so that would definitely be one place where I think flex programs could help. You know, they could work through their state office of EMS and cohort those ambulance services that have been selected. And when we first started talking about this, what, 2 years ago, it was a 1 year of selected services at a time. And now come January 1 of 2022, it's going to be 3 years of selected ambulance services, all starting at the same time. Yeah. So that's one thing I like to tell flex programs to kind of think about. You know, it really is a huge opportunity that the feds are thinking of doing something differently, as evidenced by collecting this data. So I keep telling flex programs, like, think about it. Maybe you can cohort them together. There are tools out there from the National Association of EMTs and probably others that describe those different data elements and really give some, you know, good detail about what they are and how to collect them. And I think that's an opportunity for flex programs.
Yeah, that I'm so glad you brought that up, because it's a huge opportunity. And at the same time, it's a tremendous risk if, and particularly for the smallest EMS agencies, if they fail to report or don't report accurately, they are the ones that really can show the true cost behind the, what we call cost of readiness, that, you know, being prepared regardless of your volume is where the cost of EMS is. Urban areas, big, highly sophisticated, developed systems that see 100,000 patients a year, their cost per call is actually far less than somewhere out in, you know, on the Washington-Idaho border that maybe runs 100 calls a year, but has to have, you know, $1 million budget to exist. So if those little agencies aren't getting help, my big fear is that we don't get their data, and it really will be a huge handicap on the industry going forward, you know, for providers of any type. So I think that's great that you're getting flex programs interested. It certainly meets the sustainability objectives for those very rural areas.
And that's very big picture. A little bit smaller picture, if those ambulance services that have been selected either don't report, or I believe there's a hardship exception. I don't know the details of it, but if they don't do one or the other, that penalty is substantial. It isn't a small Medicare penalty that they would receive. It's like 10 or 15%. It's a chunk. Yeah.
It's a chunk, and it will be noticeable to them. So they really do have every reason to want to participate. And I think for the ones that I worry about are the ones that really have no paid staff, that just are largely volunteer responders. Even the administration is pretty much volunteer. And I think those are the ones that you all could be really just game changers if you could engage with them. And the American Ambulance Association has a number of tools also available to help out with that. If you go to ambulance.org, there should be a link to our cost data collection toolkit, and we have scholarship grant money available for very small areas to access our online kind of self-reporting tools and other things like that. So it wouldn't cost them anything to use.
Okay, great. Any other questions anybody has? I saw a couple more cameras come on.
nobody else is going, I'll just kind of comment on the stuff you were just talking about, because I mean, that is a real challenge is kind of twofold. It is, one is those really small agencies and not having people necessarily able to participate. One thing I found in our project is being able to provide a lot of leadership tools has been helpful. And as I've listened to the other Flex presentations around the similar topics, it sounds like leadership education has been very successful for folks. And I know I'm preaching the choir here, but one of our challenges is that EMS is still seen as a transporting service, where really we're doing so much more than that, or we could be doing so much more than that. But as a 20-year field provider in a medium-sized urban area, do you want to go to the hospital or do you want to stay home? Those are my choices, not let's figure out what the right healthcare system is for you, whether it's treat in place, whether it's alternate destinations, whether it's those other things. That could even trickle down to our rural communities. If they don't have to take somebody that 40 minutes to an hour and 40 minutes away, they can keep their EMS service or unit in service by taking care of a person in place or treat in place or even to the local clinic. Then that leaves them available for their next call, and they don't need as many resources or run extended times for calls because they're out of the area because of the out of service time.
Yeah, and it'll help with volunteer recruitment and retention if there's less time on task, right? I mean, they have enough training time and everything else devoted that if a handful of the transports that take a couple hours to do don't have to happen and they get to have dinner at home, that certainly helps keep them around longer.
I had not realized that in the context of COVID, we were losing workforce to the hospitals. I mean, obviously, I know there's a workforce issue with EMS. You and I talked about that. If one of my colleagues said, "Well, let's solve it," because that's kind of what we do at the center is guides and toolkits and TA and that sort of thing. If only I could solve the workforce problem. So I didn't realize it was going to be getting worse now with COVID because their skills have been seen and they're being stolen away to other healthcare settings. I was surprised to hear that.
Yeah, it's very, all the unintended, it's not exactly unintended consequences, but ripple effects, I guess,
right.
We're still kind of figuring out along the way.
Yep, for sure. Okay. I guess if nobody else, oh, go ahead. Whoever's talking, I don't think we can understand you. Did you guys understand that person? I'm just wondering if my internet is glitching. Okay, it's not just me.
Daniel, if you want to drop your question in the chat box, we could get it addressed. Yeah, he was saying he had a bad internet connection today, so yeah.
Okay. Okay, and when I was mentioning opportunities and how encouraging it is in my mind, at least, that the feds are thinking about data collection, ET3, I think too, is another sign of that they're at least thinking about alternative models and different ways of doing things that aren't just, EMS is a transport service and that's all they are. So I also feel like ET3 is a little bit of a positive signal in that same vein.
Yeah, I mean, all in all, I do think that the future is brighter than the past. It's just going to, like everything, it'll have little fits and starts as we move along. But I am very confident that the experience that we've had in how we have handled ourselves as a segment of healthcare in the last year and a half can do nothing but push us forward, and makes me very proud of our EMS providers all over the country for the work that they've done in the last year.
Yeah, absolutely. Kind of just trying to wait 1 second for Daniel. I'm not sure if he's gonna quite make it. Okay. Well, Daniel, you can always email your question to me, or I can get you connected with Shawn to get your question answered as well. So thank you so much, Shawn. Your presentation was fantastic.
You're welcome. Thank you all for indulging me.
Indulging you. We appreciate your time. Thanks so much.
All right. Thanks.
Yeah. All right. So our next agenda item then is just to have you guys do quick overviews of what your projects are. This is what we did last year. I'll bring up the presentations and let you know who's going to talk in what order and that sort of thing. I just want to remind you, because I didn't communicate it quite as clearly as I could have, or even at all, that in this step, all I want you to talk about is just a brief overview of your project, what it is, who you're working with, and the goals of your project. Status of your project and all that stuff, that will come in Mural in just a little bit. So I will go ahead and share the presentations. I've got them all together in one file, and then let you guys talk about your projects really quick, just to remind each other. For the most part of this past program year, we met in cohorts. So the quality projects met together, and then the sustainable models folks met together, and you didn't necessarily get a lot of time to hear from each other. So that is why we're doing this way. All right, can you guys see them? Okay, great. So we'll start with the data collection and reporting projects, and I decided to mix it up and not do them alphabetical so that John Noakes doesn't end up at the very end and last, just simply because he's Washington like he always does. So we're gonna go ahead and start with Kentucky.
Well, our project is Committed to the Heart. It's the Medicare Rural Hospital Flexibility Program Emergency Medical Services Supplement, and it started. It is same as last year as far as our goals is to increase education for effective use of AEDs and location of AEDs within our call communities, increase bystander CPR readiness in our communities, and then also to improve out-of-hospital sudden cardiac arrest survival rates in our call communities as well. Our activities, and we have done some of these and are continuing to do some of these, to develop internal plan for the rollout of CARES within our, it's actually 27 call communities now, or 28 call communities and 27 calls. We want to determine where our public AEDs are. We haven't had an opportunity to go into community, but we plan to do so here this last year. Complete assessment of bystander readiness. We did this during the COVID-19 with a survey and didn't really get the response back that we wanted. So I think we are also going to try to do a post as well. And then our two changes for this year is we had some unspent activity monies and stuff as far as not being able to travel for COVID. And we had quite a bit of carry forward, and we wanted to be able to do something with that money. And we offered many grant opportunities to our cause and our EMS agencies that service these calls. And we had 7 applicants come and we were able to spend our carry forward money. And then the other change, we changed our out-of-hospital cardiac arrest measurement for the CARES initiative of it, just because we weren't going to have the overall statistical data that we were going to need to represent the state. So what we wanted to do is we still wanted to show a commitment to CARES and the CARES initiative. And we believe that having overall volume and overall enrollment, not only of our calls and our EMS agencies that service those calls, but also the volume of the overall state. Like I said, it's Committed to the Heart is our primary focus is for the 27 call facilities and our 28 counties. And it will be a statewide rollout of CARES and EMS for hospitals in Kentucky. We have added some other, like I said, other activities too as well during this time. Our partners are CAPA, K-Beams, Kentucky Hospital Association, and also the local community colleges as well. If you want to get in touch with any of us, this is our contact information. That's for the center and also for Kayla Combs and Scott Tahleah as well.
Great, thank you, Caleb.
You're welcome.
Yeah. New Mexico, you're up next.
Okay, I'm ready. So basically what we're trying to do is improve data quality, and the way that we're looking to do that is have people trained to put the run reports in better, have medical directors and service directors access the data from the reports that they put in. And by approving the data overall, then that gives the medical directors a lot better look at what's going on with the people that work under them. So we're looking at all the different areas in the state to try to improve that. Next slide. So one of the things that we found when we first started this was medical directors, number one, didn't even know how to access the system in order to utilize it in QI activities. So by doing the medical director training, we trained them to do that. But what they were finding was they were getting real poor quality data whenever they went in and ran reports and stuff to look at the service, whether that's skills or medications that's utilized or provider impression or whatever. So what we knew was we were going to have to improve the quality of the data that was being put in for that. So once again, that's one of the big functions on it. And with the data analysis works that we've been doing, we found that we have made a significant improvement with services after sending them, the areas that they needed to be improving on, and then taking another look at whether they improved on it. Go ahead to the next slide. So the partner would be the New Mexico EMS Bureau and EMS Region 3 Corporation. We actually run 2 regions, Region 1 and Region 3, but we're a nonprofit, and we have direct access to not only all of the services in New Mexico, but all of the state's data systems. So, and then lastly would be the contact information. So.
Great, thanks, Donnie. North Dakota.
Yeah, so we have rural EMS counts. It's with the Center for Rural Health, the state, the association, and ESO. I'm ready. Yeah. So we did, so Dr. Emily Crow and Dr. Tony Fernandez did a lit review of all published EMS performance measures. We went through a process that included 3 survey rounds with stakeholders, and then we went through a nominal group technique to prioritize those measures, and now those measures are available for all North Dakota EMS agencies. This is just a view of how it looks. So there are 5 categories that include a total of 18 reports or measures. So this is an example of the cardiac aspirin administration for suspected chest pain. This is fake data, but if you see, the agency is able to click on what met and what didn't meet, and they're able to get right into those PCRs and or EPCRs and see what see why it maybe fell out or why it didn't. So just by all they have to do is set the date range, and then pretty much all the kind of work is done for them. So to go along with this, we have 12 subject matter experts that are going to work one-on-one with agencies. That was just kind of, I'll update in the next part. We have regional advisors that work with the EMS Association. We've had town halls, including minutes with a medical director, where we walk through the reports and then review cases based on those reports. We have base camp where we link everybody together, and then we're creating toolkits around each measure, why it's important, what to know about it, tips and tricks. So in each of the reports, agencies are able to benchmark themselves against North Dakota agencies and a national research data set that ESO has. And so every time they run that report, they can look at those and look at their performance as compared with others. And this is my contact information.
Thanks, Lindsay. Florida, can you remind us what your project is about?
This is Mike Hall from Florida, and I just want to kind of give a quick overview of our project. And as you can see from this slide, that's our continuing timeline. I'm not going to go through all of it in detail, but kind of where we're at right now is we are in the controlled testing process with the 28 new measures that we've come up with. We've given it to our epidemiologists, and they've come up with some testing of the data. And based on that testing of the data, we're going to go back and see if we need to revise any of the specifications and see if any changes need to be made. So what we hope that will be completed by this fall. And then what we actually do is take those specifications and actually go into kind of a long-term testing of those specifications with live data, approximately up to 12 months. So we want to look at the data and see if it makes sense, if we're getting the right kind of data and going through there. And that'll go on for, like I said, a period of time. Then we'll look and see if there's any final revisions of the specifications that we need to do the harmonization with keeping us on a revised track of completing by December of 2022. So we're well in progress and things are moving along. So the other objectives we had was, and this really hasn't changed too much from the last time we reported, was to get the percentage of people that are submitting, of rural agencies that are submitting for MSTARS data, which is our version of getting into NEMSIS. Our goal was 100%. We're at 97, and practically speaking, that's 100% for us. We have one agency, rural agency. It's a hospital-based service. All I do is interfacility transfers between their campus. So there'll probably never be any type of electronic run reporting. So we've essentially, we're going to be as high as we're going to get, but we've got everybody there and everybody's being engaged with it. The next slide. And then the other part of it was to get actually all those rural agencies involved with our biospatial platform. Because if they can get to the biospatial platform, they can get on there and look at their data and compare it and do a lot of different things. So this was a pretty low-hanging objective, is just get them to establish a login. Now the next phase is to get them, which isn't a goal of the grant, but it's just to try to get them engaged and get them in using it, because it works, but it takes a little bit of training and it can be a little overwhelming at first when you dive into the biospatial platform. Next slide, please. So really, as we're going along, we're just not, this whole project just doesn't singularly focus on creating the measures. The measures is everything is building around it. So the other parts of the grant is looking at equipment needs. We have a small amount of money budgeted each year, around $30,000 each year, to try to help with the rural agencies that may have equipment issues, or specifically hardware and software issues. We had one agency we talked to, it took their crews forever to input the data because they were using desktop computers that were 7 years old. We all know that can be, that's pretty old in the computer world, and it was really taking a lot of time to input the data. The other part of it is we wanted to create a program that would interface with everything we're doing, because when the measures come out, we want our rural agencies to be able to use it and know how to use it, rather than just, here you go, here's a bunch of measures to use. So what do you do with that data? So what we've done is we've created, and it is just launched in this past month, a quality improvement education, where it's much like our EMS leadership program that we did under the Flex grant, but we created this one specific to quality improvement. So we've got a lot of different speakers on it as well, but it kind of talks about, it relates all back to our project and the measures and how they can use those measures to make their organization even better. So it's online, it's free, it's on demand, and actually anybody can get online and see it. And we're trying to create something that harmonizes with everything that we've done. So they get kind of different information they talk about measures, we talk about it, different things. So we want things to be consistent, so they're not feeling like they're getting conflicting information just because the theme may be slightly different. Again, we're really focusing on data use, is being able to how we can get them involved with the biospatial. We're doing a lot of one-on-one education. We find that works the best. And we're bringing up data that's very rural specific. We've created a measure so they can compare themselves to all the rural agencies in Florida to see how they're doing. Because what we found is if you compare a rural agency to the city of Miami, you may find the performance is different just by the number of calls or just the demographics of wherever they're at. And we're helping them by trying to create different prepared reports so they can go in, and Biospatial just came up with this recently at our request, is so we can create a canned report and send it to the other agencies where they can use it in their own use, which is helpful because there is a bit of a learning curve and a lot of these folks don't have a lot of time to really learn how to create these specific reports. And then quality coaching is the other thing we're really excited about. We have started a program where we reach out to the rural agencies as they request it, so it's voluntary. But we're working with them one-on-one to try to develop a quality improvement program. And these programs, we've designed it in such a way so it's very scalable, so they can make it for however size their agency is or whatever phase they are in their quality improvement journey. And then we're coming back and we're integrating the concepts that are in the quality improvement education and different things. We actually give them a scorecard that all they have to do is put their data in. It's all built in Excel. It'll turn red and green depending on what their goal is that they set. And it's also very limited. You know, we find oftentimes people get in these and they want to measure 50 different things at once, but we're encouraging them just to do 2, maybe 3 to get them up and running and have some successes and get everybody on board. And that's going as well. So we hope when the measures are done by the end of next year, that the rural agencies will really have something to sink their teeth in and really use for quality improvement. So the other thing that we've really discovered with working with these agencies, and it's been unsolicited feedback, because one of the things we encourage them when we're going through this coaching is reach out to their team and see what their team thinks the issues are. And it's really rewarding to see we've had more than one of the managers come back and say, thank you so much for doing that. You don't realize all of our team members are engaged in quality improvement. They're all talking about it. And we're finding that they are actually the ones coming up with the things to measure that they want to look at and they want to try to improve upon. So that's really, I mean, to me, that's really where it's all about. So we hope not only does it improve the quality improvement, hopefully it improves the engagement of the people in those organizations, and hopefully they can retain, I mean, hopefully it'll eventually be a recruitment and retention tool. Any questions from anybody?
Thanks, Mike.
You're welcome.
All right, moving into sustainable models of rural EMS care. I just want to remind you guys, let's do brief overviews for right now. We're going to move into really giving some updates of year 2 as compared to year 3 as we move into the mural work. So John Noakes in Washington.
All right, that was a picture of me. In the first quarter of 2019, we sent out the 18 attributes of successful EMS services survey to all agencies in our state. Out of the 481 agencies, almost 70% of our agencies either are rural or have a rural component to them. We ended up getting about an 83% return rate on those surveys. Next, please. What we found was that the 4 main areas of low scores across our state, not just in rural EMS, were recruitment, retention, EMS leadership, any kind of public information or engagement strategies, and just really low involvement with the community. And those are the 4 areas that we wanted to focus, work on. So we applied for and got the Flex grant. Next. We were really looking at this from 2 different areas. Strengthen the workforce. We're working on creating action plans based around the 18 attributes, increasing, or I guess it wouldn't be not only increasing initial EMS training, but also reducing the barriers to entry into initial EMS. As you heard me talk about earlier, one of our original goals was cross-training into some sort of community health worker, but we faced some challenges with that. We've been working a lot with community involvement. We've had lots of different speakers come in and talk to us about different ways to engage with the community, and again, how to create action plans on what to actually do. Next. We have a few partners, Office of Rural Health, EMS is taking the lead on this. We have some other health professionals. I don't know whether we actually consider them partners or not, but we have worked with a lot of contractors to either provide full-on leadership courses like Safe Tech Solutions leadership course, and just subject matter experts that come in and give 60 to 90-minute presentations on a monthly basis from a wide variety of sources. And next. And there's that. Thank you.
Thank you. South Carolina.
All right. Hi, everyone. I'm Britton Herbert with the South Carolina Office of Rural Health. Our state's project focuses on EMS agencies which provide service to counties without a hospital and allows them to select at least one of 3 new models of care: community paramedic, alternative destination, and/or telehealth, treat no transport. We aim to elevate the role of EMS in our state to really help fill the needs in a community that otherwise might have some lessened access to care. So we have 5 agencies participating, which serve 6 of our 8 counties without a hospital. You can see our participating counties on the map. The first cohort is in blue and the second in green. Our project is to have each of them develop a community paramedic program to operate within their county. Then they can add on alternative destination or telehealth. We're helping the agencies develop and adapt these models to best fit their agency. And we'll be analyzing the impact and telling their story. So beyond the implementation of these new models, we're really looking at getting some Medicaid payment for the community paramedic services, something our state really has yet to have, even though we have a variety of programs already across the state. So this is certainly kept in mind as we develop what data we're collecting to make sure we can tell the story and make this case. Secondly, while in the public health emergency, there were some allowances created for alternative destination and telehealth programs. We want to make sure that these new models of care have approved pilot programs in our state so that they can stay and continue to be around for all of our rural EMS agencies. And finally, we want to show the benefit of these programs just through the improved chronic disease outcomes for the residents of the county, why we're really doing all of this to begin with. And of course, partners certainly couldn't do this alone. So we've partnered with the agencies which are developing the models, the education providers for community paramedic courses, our telehealth experts in the state, our regulatory body, DHEC, for the development of the pilot program requirements, and more, and all of the other various partners that make sense within each county specifically. I think that wraps up my intro.
Thank you. Arizona, let's hear it, Joyce.
Hi, everybody. So I'm happy to present this brief description of the project that we're doing in the state of Arizona, is building this sustainable model for EMS medical direction on using telemedicine. And so it's in 2 counties. You want to go to the next slide? Mm-hmm. So it's in 2 counties in Santa Cruz County, which is about 50 to 60 miles here from Tucson, going towards the Mexican border. And so these are 2 very rural counties and very rural EMS agencies, and they're about maybe 20 miles from each other. So the thing is to work with the Banner Health here at the university in getting referrals using telemedicine. And of course, we want to reduce the cost of that, but more of what we want to do is avoid those unnecessary transports. And it's important for these communities because, again, it's very rural, very mixed ethnicity down in these 2 rural communities on the use of telemedicine. And so that's been, an interesting process over these months. Next slide. So we have a host of partners, one of which is the Arizona Emergency Medicine Research Center, where Dr. Amber Rice and Dr. Josh Gaither work, and they're providing the medical oversight through the ER. And of course, the technology that is being used in both of the communities that I identified at the agencies, FirstNet, and then how that interfaces with the Arizona telemedicine program. And there are the names of the two agencies, Rio Rico Medical and Fire District and the Sonoy and Elgin Fire District. And again, because we have treat and refer through our Medicaid program, we're working with the Arizona Department of Health Services on that. In fact, Rio Rico was the first in the state to become recognized as a treat and refer agency through Access, our Medicaid program. Next slide. So sorry that Eileen Hardcastle is not here. She had to go to Europe for family emergency. And so I'm doing the best I can. So I'm not integrally involved with it at all, but I'll answer any questions that anyone has.
And Jill is on vacation too, so you are
Yes.
like kind of doubly alone, if that's possible.
Yeah, but we keep up, but Eileen could do a better description, but
yeah, I think you did great. Thank you, Joyce. All right, Daniel, let's test your new connection and see how you're doing.
How do I sound?
Oh, much better.
Besides being sick.
Oh, sorry to hear that, but much
That's
better.
okay. Oh, good. So in Ohio, we are doing the Community Paramedicine Rural Sustainability Project. The goal is to create a self-sustaining model that other EMS and hospitals can replicate. So the way that I structured it in Ohio is that an EMS agency had to partner with a hospital, preferably a CAH. So we funded 3 CP programs. 2 of them are tied with CAUS, and 1 of them is a PPS hospital. So our partners were the EMS agencies themselves, the hospitals, the Paramedic Foundation supplies technical assistance, and then the Department of Public Safety. They're the ones that they do the licensing for paramedics. So we work closely with them as well. So when we were picking the sites, we had a couple criteria. One, they had to serve a rural Ohio area. We preferred it to be a county, but actually, yeah, none of them are currently serving the entire county. Ohio is a little weird where half the state, they are county based, and then the other half of the state is more township based. And like I said, it needed to be a partnership between the hospital and the EMS agency. And we wanted them to focus on reducing 30-day readmissions, ambulance run, and increase ED avoidances. So the things that they needed to supply to us is a work plan, the metrics that they were going to use, their staffing, actually breaking down the model. And currently right now we're receiving quarterly reports with their metrics, but at the end of the project, we're going to publish the different models and what their metrics results were, so that hopefully other EMS agencies and hospitals can use that as a launch, either as a launching or a proof of concept to their finance people to get it approved from leadership. Nicole.
Yeah. Yep, and that's your last slide. So yep. The next slide would be contact information if that was there, but maybe it was at the beginning. Yep, it was. So if you have any questions for Daniel, or actually if any of you have any questions for each other about your projects, clarification, feel free to ask it, but just remember we are going to get into changes that have occurred to your project. Going into year 3, we're going to get into measures. We're going to talk about, really get into the current status. So any questions about just generally what the projects are, you can feel free to ask them now. All right, not hearing any. I'm gonna try to find my little bar so that I can unshare my screen. It's going. Okay. So now we are, am I still sharing my screen? I can't make it stop. Okay.
You're not sharing.
I'm not sharing now. Okay, perfect. So for the next half hour, what we are going to do is move into our first section of state sharing. So I guess we've kind of already been there as you talked about your projects and reminded each other what you're all working on. But now what we want to do next is our first chunk of mural work. So you guys might remember we did this last year. I think you guys figured it out and seemed like you liked it. So we're going to do some more of that. TASC staff will be bouncing in and out of the rooms to make sure that you don't have any problems. But over here really quick. So we're going to do some individual state small group work utilizing breakout rooms within Zoom. When you get into the breakout room, please identify one person within your group to scribe. I do realize that there are 3 of you that are only one person. So we'll come in and talk to you, but you also don't have to sit in a breakout room by yourself. Once you do the mural work and we're able to get it all done, feel free to leave the breakout room. But like I said, TASC staff will bounce in and out to make sure you guys are good. As we go into the breakout rooms, the main purpose is to be viewing the mural application, which I will paste a link to here in a minute. And so you can minimize Zoom. And when you minimize Zoom, you should be able to see just a small icon or a small box in the upper right-hand corner of your screen where you can still see, and you should easily be able to hear each other, but really mural will be kind of your main focus once we get in there. I wanted to share with you guys really quick about the outline in mural. So let me just share my screen really quick. Okay, once you click the link, once I provide it to you, you'll see something like this when you log in. I'm assuming everybody's seeing mural now. Good, okay. Along the right side here is the outline. If for some reason you log into mural and it's not there, up here in the upper right-hand corner, there is a box with 3 dots and 3 little lines that will bring up the outline. And once you get in there and find the outline, what we want you to do is find your state and in the list and click on it. There are some instructions there in the box that has your state name, but things should be fairly self-explanatory when you get to your state's layout. So the first thing that we are going to start with is to have you share the status of your project. At the end of year 2, you're basically at the end of year 2 right now as compared to your overall 3-year goal. And then we want you to move down in here and talk about what your successes were in year 2. So like your main accomplishments. We also want to hear from you what your sticking points were in year 2. What kind of problems did you have? And then we want you to also note what changes you are making going into year 3. I know a few of you have activities that are changing. With those activities, are your goals changing? The things that you intended to accomplish with your project, have those changed? So just succinctly, briefly, things that, little statements that add clarity, not too much detail because you're going to talk about it anyways. Down here is a peach colored box that says task use. When we come back to the main room and are reporting out to each other, we want you to feel free to talk to each other. So if Daniel in Ohio is talking about a sticking point with his project and somebody in the room has a suggestion about a resource or a way that they might address that or communicate about it, feel free to have those conversations, but we will take note of those suggestions for you so that they're there for your reference once this meeting is done.
Nicole, this is Joyce. I have a question.
Sure.
since you got an email from Eileen with sort of detail, because I can't really fill that stuff out in the software. So with what she wrote for you, can you just like put that in the boxes? Or because I mean, I haven't not been that detailed information on all the ins and outs of what they're doing. So
Yeah, I will come into your breakout room and you and I can work through
great.
that. Yeah,
Great.
I'll come in and work with you on that.
Since she has the detail outlined, yes.
Yep, yeah.
Good, thank you.
Yeah, any other questions about this? Does it make sense? When you click the mural link, the first thing you're gonna do is go look for the outline on the right side. If the outline is missing, this little box right here should bring it up for you, and then find your state in the list.
I think the other part too is just to not worry about, there's more in the mural about outcomes and things like that. We don't need to fill in those parts yet. We'll get to that later on.
Yeah, right now you're just concentrating on the status of your project and then these 3 boxes right here. Sound good? All right. Andy, will you go ahead and send them into their breakout rooms?
Yeah, I will open. Do you want to put the mural link in the chat, Nicole?
Oh yeah, absolutely. And there will be about 10 minutes for this. Shouldn't take too much longer than that, but we'll, like I said, we'll be checking in on you to make sure you're not struggling with mural so that you're able to work. There's the mural.
Sounds good. And I'll just give everyone a sec to click on that link, and then I'll go ahead and open it. And there'll be a 10-minute countdown, and then it will start at about 120 seconds where you can rejoin the main room, but you can do that at any time and feel free to work up until the last second. So I'll go ahead and open that now.
All right, welcome back, everybody. I hope mural worked for you or that you got the help you needed if you had any problems. So we're going to do a quick report out. I don't feel like you need to read every word that you necessarily typed, but hopefully your statements were kind of short and succinct. And so I just want to spend a little bit of time having you all just reiterate what you put into mural right now. Just talk a little bit about the status of your project at the end of year 2 as you head into year 3. And then really quick, what your couple of successes were and what your sticking points were. And with sticking points, if anybody in the room has anything to add or contribute or suggest, definitely feel free to do that so your peers get that information, but also we'll take notes in mural of any suggestions made. So Joyce, starting with Arizona, as Joyce said, she hasn't been following the work in a very hands-on way because not that she doesn't know what's happening with the project, but somebody else is actually doing the hands-on work. So Joyce and I copied and pasted information that was provided to her. So Joyce, if you wouldn't mind just reiterating kind of briefly what it is that Eileen shared with us before she flew off to Europe for her family emergency.
Sure, thank you. So like, what was the order again?
Yeah, starting with the status of your project at the end of year 2 as compared to the overall 3-year goal.
Okay, well, the 2 agencies I mentioned, they're very active, engaged in this pilot program. They're using the eBridge telemedicine platform, so that's going very well. And they're on track, collecting data after each call, using a REDCap form that Eileen designed. And they're comparing that to de-identified patient data from the state's EPCRs. They believe that the statistical analysis of the data to begin early next year. So that's really good. The biggest, the main lessons learned, I think that was the next one. Oh no, it was 2 or 3 of your biggest accomplishments. that the agencies are engaged with the telemedicine platform and that patients are being positively impacted. And they're seeing the number of unnecessary ground and air ambulance transports decreasing. So that's really good news, especially when you think about the cost of that. And some of the sticking points that they had. Yeah, so I think I've mentioned this on other calls, but with Rio Rico, the leadership change that occurred at Rio Rico from the time the proposal was developed to when the new chief was hired. So there was some, really education that needed to be done. But everything is turned around. I know that Eileen was going there for night shifts, weekends. That face-to-face really, really helped in convincing them, answering their questions, being there, getting them to know both the staff that are working on this project, as well as what is required. So that really, they turned it around, and that's really, really exciting. And then I think that's it.
Yeah. And then going into year 3, you guys were not making any changes to your goals or activities.
They're not making any changes. They're right on track on what they designed originally into the work plan. So which is good. So yep. So they're just going to proceed. And this third year is really the analysis. So to see that they're collecting the data that's necessary, putting into REDCap, those forms being designed and things being entered directly will make for the analysis quite easy. So, and comprehensive.
Great. Any comments or questions for Joyce, thinking about the sticking points or successes, how they've gotten to where they've gotten? Any questions at all? Feel free to ask.
Well, in just reading again what Eileen said, and I did fail to mention, was the language and cultural barriers. This is Santa Cruz County again, at the board, county at the border. And so being able to understand not only the people who live there, but also the staff, and how what they've had to do in working with them, and as again reiterating that Eileen and the doctors being down there, being available to answer questions, make it more relevant, has been really key. So those challenges of the mix of who is served down in Santa Cruz County, a big difference. So.
Yeah. Okay. Suggestions or comments for Joyce? All right, we will move on to Florida then.
Thank you.
So Mike, I think when you did your presentation, you gave us a pretty good idea of what you've accomplished in year 2. So I'm not sure you need to say much, if anything, about the status of your project. So maybe we could move right into your successes and your sticking points. Oh, you're on mute.
So in year 2, as we did the control testing, we found that the data quality was a little lacking, shall we say. And so that's a bit of a struggle, is trying to get the good clean data, because a lot of things got kicked out because the data wasn't real clear. The other thing, even though we were supplying equipment for our rural providers, there's the semiconductor thing kicked over and for supposed to be laptops, so it's a big delay in getting laptops. So we've got them on order, they're coming in, but it's going to take a while to get the equipment in. So that's been a sticking point for us as well. And probably the last sticking point is really just the processes working through state government. The processes just seem to take longer than what they should. So that's a bit of a struggle. So we challenge, that's a challenge for us day in and day out on different things.
The data quality issue, is that something you've mostly overcome, or is that something you're working on?
It's something we're working on. I mean, we're trying to go back and seeing if we can, if there's any way we can clean up the data a little bit, or filter it better so we can get some more accurate information. But we're going to have to make a real effort. I mean, going forward, I think, the data that's there, we're stuck with kind of using, maybe just be a smaller set. We think it'll give us good indications. And then going forward, we'll just have to figure out a way to focus on improving the data quality. And that's going to be an ongoing project.
Sure, like educating the ambulance services about the issues with the data, like data elements, better understanding them and what you really want to see from them.
That's a component of it, but another component can be even just the linkages. They may not be communicating, their software vendor may not be downloading this. So we need to help with the agencies to try to identify that and fix that as well. So it's one another possible cause.
Okay. Great. Anybody have comments, questions, thoughts for Florida? All right, Kentucky. Start with just a quick status of your project in year 2 as compared to year 3, and then talk to us really quick about your successes and your sticking points, and then if you made any changes to your activities, goals, objectives going into year 3.
We feel like we're pretty spot on as far as what we're wanting to do with our overall goals. Like I said in my earlier presentation, we have made some changes, but I don't think it's anything that will change what our the overall goals of the presentation or overall goal of the initiative itself. As far as our year 2 successes, if you go in a little closer there so I can see a little better.
Yeah.
Where our many projects at the community level, where we were unable to get into community, we were glad we were able to provide those funds so that local hospitals and local EMS could do what we wanted to do, go in and educate on CPR, educate on AED usage, and actually get some communities and people in their communities certified for CPR. We're talking about full school systems and everything. So that has been a big sticking success for year 2. Sorry, I'm still having trouble seeing. Could you go a little closer?
Yeah, for sure.
Okay, yeah, for onboarding for the calls for CARES, we have 14 in the process and around 30 or so EMS agencies. So onboarding has been a success. The core staff has prepared providing CPR training. Scott and I have both gotten there. Well, Scott's always had it as paramedic, but me, I got my CPR license, and I'm also getting my certification for teaching. And we are going to be able to go into these communities and offer some educational classes starting in year 3. So we're excited about that too. We didn't want to give up on that portion of the grant. And then our continued successful partnership with K-Beams. It's been a very good working relationship.
Great. What about your sticking points? What are you guys kind of struggling with?
The biggest thing was we found that we weren't going to get the data we needed from CARES to be able to show any significant improvement or even give a baseline, just because of the number of facilities and EMS agencies enrolled at the time. Hopefully by year 3, we'll get some data, but not enough to make a significant difference. So we were glad that we were able to find that. We were able to get that measure changed and still make that portion of CARES a success for the grant overall reporting too as well. And COVID delays and restrictions, as far as that, we couldn't go. I still haven't visited a single call facility, and I've been with the Corps now for almost 2 years. So that's been one of the biggest sticking points too as well.
Yeah, and that's probably not going to get any better, honestly.
No,
COVID's spiking up all over the place again, so yeah.
And then as far as our changes go, like I said, we were able to do the mini grant project for the carryover funds, as well as changing the measurement for our CARES. That's been our only 2 major changes.
Okay. Questions, thoughts, suggestions for Kentucky from anybody else? Okay, moving on to New Mexico. Start at the top there with your current status at the end of year 2 as compared to your overall 3-year goal. Successes, sticking points, changes.
So the overall status is we're right on track with the project, and I think the 3-year goal is going to be pretty easy to obtain unless something weird happens. So, you know, with the current data system that we've got, everything seems to be functioning properly, and, you know, we don't anticipate any problems with it. So looking at some of the successes, you know, our ability to obtain statewide data has been problem-free. So, you know, that allows us to do things like whenever we get contact from NMSIS with issues of maybe a service not reporting or slowing down their reporting or whatever, it's easy enough for us to go in and troubleshoot and take a look at why. So it may be that, you know, if they're a third-party submitter to the state, it may be that they're flagging their runs that they need to be reviewed before they're sending them to the state. So that data is not coming through. So we're able to go to the service and, you know, try to make corrections on that. And then also having access to the statewide data gives us the ability to easily do comparisons like, you know, data improvement. We can compare rural services to urban services to find out, you know, if they're comparably the same at putting data in, and if not, you know, look at some of the reasons why. So that's been a real plus for us, is that constant ability to look at state data. And then also we've continued the training of the EMS administrators, the medical directors, the service providers. And that's been really important because, you know, we've been able to sit down with them and not only show them, you know, some of the data elements that the state just really needs, but also, you know, just basic things on, you know, what they need to be inputting. And then we can also show them the outcome of that. We can run data reports for them or allow them to run their own data reports so that they can see the importance of quality data whenever they're doing those reports. So, you know, if you take a look at some obscure report like how many times Joe Smith is starting an IV with an 18 gauge catheter after 5:30 on a Friday when it's raining outside, you know, we can go in and show them that. So kind of opens their eyes to what the abilities are for them to do different data reports. And then also something we noticed, you know, through this training, through, you know, contacting services. Right now we're sitting at, with the last group that we've done, which we're doing 40 new services this year, looking at 20 data elements. The past 2 years, we did 40 services, looking at 20 data elements. And we looked from the first time we contacted them to the second time, whether or not there was improvement. So now we've done the next 40 services and we found only 10%, which was 4 out of the 40 that were actually poor at inputting those records. So, and some of those services are pretty urban services, but we made contact with them. We've let them know basically where they're standing and things that they need improvement on. And then next year we'll look at them for a second time and find out if there's any improvement on that. And then we'll continue to look at different services, but at the same time, we are looking at all the services that are submitting data to the state. And then last of all, which was pretty interesting, was that we found that rural services are now inputting data as well as the urban services, and the overall completeness of the run reports is somewhat equivalent. And, you know, that's kind of exciting, you know, whenever you go in and look at a rural service with rural volunteers that, number one, didn't even have time to go on the call to begin with, and then complete a good quality patient care report afterwards. That's kind of saying a lot towards it. So that's some of our successes on that. So if you want to go over and look at the main problems. In fact, you labeled them as sticking points. I labeled them as lessons learned, but you know, some of the biggest lessons learned was we found this out in some of our small meetings, is that we need to really be looking at rural services more than urban. So we've taken a lot harder look at the rural services, and that's where we found out that they're reporting as well as the urban services. So we're going to kind of shift our concentration and look at some of those rural services and make sure that, you know, they're not experiencing a lot of issues. But, you know, we do run a 5-day-a-week technical service, and, you know, a lot of these services call in, we assist them on a daily basis. So, you know, it does help us to look at, you know, what the rural services are doing out there and the problems that they're experiencing. And then the second lesson that we learned is forget the assumption that things are going to return to normal. I don't think they ever will. I mean, with the Delta variant coming out and things happening, nothing's going to return to normal. So we'll continue to provide alternative ways to accomplish the overall project goals, whether that's Zoom meetings online or, you know, Zoom medical director sessions and things like that. So, you know, basically that's the way that we're approaching the final year in this.
Okay, thank you. Questions, thoughts, etc. for New Mexico? All right, moving on to North Dakota. Go ahead and start at the top and then work your way down through the successes and sticking points and changes made, etc.
Sure. So we're slightly behind in year one, but I feel like year two we've finished what we thought we would, and are finishing year three where we want to be at with the measures available, and getting really into the data and the quality, and using the measures for both quality improvement and improving documentation. So year two successes, we had an in-person subject matter expert meeting, which really got kind of our subject matter experts all on the same page and kind of understanding their role and the project. The measures became available in the software this year. We started minutes with a medical director, where we have rural EMS medical directors come on and give feedback based on the measures, like actual kind of case reviews that either they met the measure or they didn't. Lots of medical directors have raised their hand because they want to help, so that's good. With our carryover funding from last year, change to the project, originally we kind of piggybacked back on a different project that connected critical access hospitals and EMS agencies using health data exchange. So care providers are able to get that, what happened at the hospital, that feedback directly and pretty quickly. And so we were able to pay for critical access hospitals to do that. And we got 4 to sign on that will be done before the end of August. And so that is good. And then we've helped EMS agencies get onto that. That was through Helmsley Mission Lifeline Grant. That was free to EMS agencies for 1 to 2 years. So we've really helped them get on base with that, because we feel like having the complete patient picture is very important. And 2 of our measures are based on hospital ED discharges. So sticking points, I think EMS in rural areas is very independent, and I appreciate their spirit. And so they're not really one to ask for help. So kind of allowing help is something that we're still working on. I think we have a lights and sirens measure. So culture change is really, that doesn't come overnight. Remote, again, rural is kind of in-person handshake kind of thing. So remote, well, it's been nice for those of us that don't have to travel. I still just don't think it quite has the same impact. And data access, we have to request every time we want access to the reports and the measures from the state. So And that just, I think, is how it will be through the end of the project. So no changes to the project, and really just working on the project as it is planned for the next year.
Thanks. Questions, comments, thoughts for North Dakota? All right, Danielle, are you still hanging in with us?
Yep, I'm here.
Okay. Start at the top and give us kind of a brief overview of where your project is at the end of year 2 as compared to year 3, and then work through the 3 boxes under that.
Okay, so year 1 was taken basically all just getting contracts in place and picking the 3 sites. And then year 2, we've now, all 3 sites have started seeing patients. One has even hired their community paramedic, which was always their plan. But then another one of the sites has had enough referrals that they are hiring a full-time community paramedic, which they weren't. They were hoping they would do, but obviously they needed to have it. They were okay using their existing staff until they got the numbers high enough. So we're pretty happy that they were able to get to that point. I'd say the sticking point that I wasn't expecting the most was getting institutional approval. So one of the EMS agencies is standalone, so they were able to kind of just start off running. But 2 of them are with the Mercy Health System, and they had to get IRB approval and that should be ACO, not ACA, Accountable Care Organization approval. And that they really struggled on that. The Accountable Care Organization wanted to make sure that they weren't cannibalizing their patients. So that was new, and we weren't expecting that. So I'd say that probably delayed them about 6 months. So in a 3-year project, I mean, that's 2 quarters of data that we're not going to get now.
Right.
One of the sites is kind of having some problems getting buy-in from neighboring agencies. Like I said in my intro, not all my EMS agencies are county-based. So for that one to be the most effective, he needs referrals from neighboring EMS agencies.
Oh, sure.
Not needs, but would like referrals from them. So he's working on that now. And then just like all community paramedicine and EMS in general, they're just, I think it's always a constant struggle just trying to find enough money.
Yeah. I guess I'll just ask any questions, comments, instead of like my default is always, hey, I have all these suggestions, but suggestions from your peers. Anybody have any suggestions or thoughts that they would like to add, whether it's sticking points or questions about how Daniel was able to succeed with something, etc. Okay, I didn't let you cover your changes. What kind of changes do you have coming?
So one of the changes was just, I just was saying that it was delayed because of the ACO and IRB approval process. And then another one was just trying to make sure that the metrics were all specific to the individual agencies, which obviously I couldn't have foresaw what metrics they would need when I wrote the grant because I didn't know which sites were going to get the grant. So trying to be flexible with and make sure that the metrics are relevant to each site.
Okay, comments, anybody for Daniel? All right, thanks, Daniel. We'll move on to South Carolina. Just starting at the top, give us an overview of where you're at and then work your way down.
Awesome. Yeah, so we've made a lot of progress in getting some of the programs, the groundwork laid for those, for things to really burst forth in year 3 for us. Some successes in year 2. We started with 3 agencies in the first year, and we actually added 2 new agencies over the course of this year that'll participate for year 3. They had been very interested and eager at the start of things, but just in light of COVID, they just didn't have the workforce at the time to participate. So now they do, and we're excited to have them on board. All three of the first year cohort have sent individuals through and completed the community paramedic didactic proportion of the certification. And in addition to our year two cohort, all of them again have more employees that they're going to send when the next class opens up. So it's great that workforce is available now for this, and that they have such a drive within all the agencies to just continue pumping resources into these new programs. Another success that we are optimistic about is that some of these, the year one cohort at least, will be able to get some funds from the government to help enhance some of the relationships that we've really been building with their transport hospitals as we've been developing these programs. And they might get some software and some extra kind of funds to help continue building those relationships that they've seen have been a benefit. So that's been great to see. Sticking points, I mean, of course, COVID and everything that it has just done, especially when it comes to completing the community paramedic certifications. The clinical portion of it has really been a bottleneck. Most of the organizations that usually allow shadowing and ride-alongs and complete the long list of things that need to be before you can go for the certification just aren't accepting people yet. We're starting to get some of those kind of reservations and signups in place, so we can start really cranking those out come the fall. But that's been the biggest thing. But we've at least been able to work on a lot of the back end side of things up until now, getting all of those procedures and protocols and everything in place, so that once people are actually trained, the groundwork's laid and we can start seeing patients. And then changes there, other than adding the two new agencies, kind of just minor things that we had an agency that even before we've gotten the pilot program in place have been able to see patients through the alternative destination model as a allowance from a COVID restriction being eased. Sure. And that through kind of reevaluating the programs and seeing that we'd planned that you could do an alternative destination or a telehealth piece on its own. Instead of we're having everyone do a community paramedic piece first and then add on an alternative destination or telehealth component to that, as it just kind of is a logical step of building the agency in that direction before expanding out to that either of those pieces. So a bit of a mindset change for us, but not a big effect for goals and such.
Sure. Okay. Questions, comments, thoughts from anybody for Britain in South Carolina? All right, Washington, tell us how it's going.
It's definitely going. So for our overall project of increasing sustainability in our rural agencies, I think we're still right on track to do that. What the plan is to do that has changed a little bit. Really, like the others have said, year one was getting things in place. You know, I got my position and then COVID hit, and we had to regroup for a little bit, figure out where we're actually going. So as far as the actual project work, that really didn't get started until August of last year. So right at the end of year one. In some ways, it's hard to believe it hasn't even been a year yet. and in other ways, because we've done a lot of work with the agencies. So for some of our successes, I finally actually have 12 full agencies enrolled in our program, which was our target goal. We started out, I had 12, then one dropped right before we actually started the project, and then one dropped right as the project actually started. And then throughout we had 2 more go out by attrition, which is when we started looking and coming through again. Part of the reason the agency dropped is they don't have the personnel, the time, or the structure to even participate in a fairly straightforward project like this. So my question keeps coming up: how do we help our most vulnerable services that don't even have the ability to participate? We've been doing monthly subject matter expert presentations that are based around the 18 attributes, which is the core of our project. So we've had financial speakers come in, we've had community engagement speakers come in, mental health and wellness speakers come in, just anything that really revolves around those 18 attributes that are the personnel enrolled in the program can take away. I guess I should have said also the 12 agencies we have enrolled. It was encouraged that it was the leadership or the closest thing to leadership that these agencies had, so that they can build and bring those things within their community. Some of our agencies are very highly involved. They're taking the time to be there. They want to be there. It takes a lot out of their time, and I appreciate when they show up. Some of them, because of their normal lives, they rarely make it to the actual live meetings. However, all of our materials recorded, and they do watch it later. And I hear from them later, like, yeah, I watched that, or I shared it with my neighboring agency. We shared it with the commissioners, whatever was appropriate with that. So I feel they're definitely taking stuff away from this. And if you look at some of the action things they've done within the departments that took place after these subject matter experts, it's definitely made a difference for them. Because I do have quarterly meetings with agencies one-on-one to just kind of see how they're doing. The biggest thing out of year 2 was really learning more about the actual needs. When this grant was written, there were a lot of assumptions, which I thought were also true. I came from an area dealing with an agency that runs about 2,000 calls a year. They're still volunteer, but they live in a community where there are schools, where there's clinics, where these other parts of infrastructure exist. So I'm like, oh, you want to teach a class you're struggling? Go to the high school and see if they'll help you out with technology and equipment. The agencies are like, yeah, we don't have one of those in our district. Or, they're very, very small communities. They're very much out on their own. Part of it was to decrease the barriers to initial EMS training. Like, hey, we're going to give them mini grants to fund EMS training. They're like, great, we have these grants partially because of COVID and partially because of their location. They're like, we can't find anybody to put on classes for us because they're short. So I'm like, well, we funded you, now what? And they don't have the infrastructure for training. The other big one that Lindy was talking about is, across the state, not just in our enrolled program group, is we're getting a lot more stakeholder awareness that we exist, that we're doing some project work, and people are really interested in what we're doing and really want to see what comes out of it. So those were some of our successes. So let's talk about some of the sticking points or major things that stick out. I touched on already, but really our most vulnerable services lack the structure of the personnel to participate. And really I know I'm not going to solve it by the end of this project, but really trying to come up with solutions and come from there. I actually have a meeting with one of our presenters from the reverse site visit. I have a meeting with them in a couple of days, and we're going to talk about some of those things. So I'm learning from the projects we're involved in too, making contacts. I touched on it earlier in the presentation. Some of our goals are unachievable for the enrolled services. One of our big goals was to do cross training with, sorry, that was still in sticking points, but it's all right. Is we made these goals, but like they're cross trained into other healthcare professions to keep those, I work at the clinic during the daytime and I can run EMS at night, or maybe I can leave the clinic. Those communities that we enrolled don't even have that kind of infrastructure. So making sure that the goals are set are achievable. And so example, we've shifted. The two other things, one I didn't get time to write in here, but the one is the agencies, when you reach out and say, hey, we're from the Department of Health. And once I tell them I'm a rural person, it definitely helps, not the west side of the state, but we care about what's going on here. We're interested in helping you. They've really appreciated what the state has done to step up and to engage with them and help them come up with solutions. They appreciate being heard and being thought of. Mm-hmm. On the other part of sticking point is with our meetings like this, again, we do these monthly meetings, they get to hear that Agency A is having these struggles and all the other ones go like, wait, we're having the same challenges and the same problems. And they're building a community that way. They don't feel like it's only them that's struggling, which makes them more willing to ask for help or let them know what their struggles are, because we're not the only one. When you're not the only one facing a problem, it makes life easier. Mm-hmm. So some of the change we made is, again, we've talked about shifting some funding. So we're not working on the cross-training folks at this time. I think it's still a viable option if we were to jump up a level of vulnerability or reach out to communities that had that type of infrastructure. But what we did do is, from some of our carryover funding, and it's going to be written into our year 3 plan, is there's funding to increase instructors within those departments. Can they get their own EMS instructors? Can they get their own CPR instructors, driving instructors, whatever's needed to keep that service sustainable? So when the project's over, they will still have those training opportunities. I talked about not being able to get EMS classes. Currently, myself and one of my peers that deals with education and training for our state, we are working on creating a best practices, and we're going to pilot a remote EMT class where we're going to have anybody in our enrolled agencies who have personnel they want to send to this, figure out how to teach in multiple counties and multiple geographic locations across multiple MPDs and put on a successful initial EMT course. So we actually, as soon as this meeting gets over, I have my next meeting for that. But we're currently on that, and I'm really excited what that's going to bring for opportunities. Everybody's been picking on COVID, and I'm not saying COVID's a good thing by any ways, but it's forced us to change how we look at stuff, and it's creating some amazing opportunities for rural EMS where people can't just dig in their heels anymore and say, no, we can't do that or that won't work. We say, well, this is now your option. We're going to make it work, and we're going to figure out how to make it work.
Yeah.
So, all right, questions, comments?
Yeah. Anybody have anything for Washington?
Awesome. Thank you.
Yeah, thanks. So that brings us up to a break, and we are a little bit behind schedule. So, but that's okay. Let's go ahead and take a 15-minute break. So we'll see you back at about 5 minutes to the hour. It'd be 3 o'clock Central Time, but I know we're all in different time zones. So 15 minutes from now, about 5 minutes to the top of the hour.
Looks like, all right, I think we'll get started then. So for the latter part of the day today, we're going to start focusing more on kind of proving the success of your project and also talking about sustainability. So first, I'm going to just lay some kind of basic groundwork about some concepts with sustainability to help kind of get everybody on the same page as we move into the last part here today. So first, I'd like to just kind of share some definitions. So there's lots of different definitions about sustainability that are used by different funders and researchers and community-based organizations. But the Georgia Health Policy Research Center has created a sustainability framework. And if you're not familiar with Georgia Health Policy Research Center, they do a variety of different things, but they also receive a lot of funding from the Federal Office of Rural Policy. So very much a trusted partner. And they've described sustainability, generally speaking, as, because there's so many definitions, is that sustainability occurs when there's programs or services that continue because they're valued, and so they draw support and resources. So they're identified as sustainable because they're proven to be valued and then draw support and resources because of that. And sustainability doesn't mean that the activities, back in the previous slide, Andy, so sustainability doesn't mean that the activities kind of continue in the same form as originally kind of thought of or funded or implemented. And as we've been talking about your programs today, they often evolve over time to adjust to the changing levels of support, the needs of the community, the pandemic, all sorts of different things. And so organizations oftentimes start with one approach and then ultimately elect to sustain a different model of service after kind of proving the test in the community about what really is needed and successful. So on the next slide, again, from the same resource, Georgia Health Policy has described in the sustainability framework what the most successful and sustainable projects really include. And those most successful and sustainable projects can demonstrate a vision, they can use leadership to leverage the success, they can clearly communicate about what their project is, why it should be valued and supported, they actively collaborate with others and seek new collaborations, they're relevant to the need in the community, they're efficient, they're effective, they can understand and describe the relationship between the short-term activities and the long-term successes of where they're trying to go to. They're practical, and they're aware of their realistic capacity. They're not trying to overachieve based on what can be accomplished. It's pretty bad if you clearly communicate all these amazing things you can do and leverage all these collaborative relationships, and it's not within your scope of capacity to do something. So lastly, just briefly here to share with you what there are some strategies that can be utilized to help achieve sustainability. And so this is from another great tool from another great federal partner, and that's at Rural Health Information Hub. And so there's kind of 5 different strategies. And the first is to strengthen your partnerships. And so this is important to, having partnerships has kind of the most greatest potential for lasting impact to your project. So I'd really like you to think about where are your current weak links in any partnerships you may have. And that could be internal, the people that you're working with on the project, even within your own organization, or externally as well too. And what are the ways that you can get them all engaged? And where are your strong links that you can leverage to kind of loop in others to build new relationships? Building capacity is incredibly important, of course, and many of your programs, share today some training components. So when you're doing trainings, are you not just assessing that the training occurred, but that there's a proficiency change that happened because of the training? And can you leverage things like the train-the-trainer model that some of you are utilizing to kind of improve the spread and kind of share the wealth, if you will? Diversifying funding streams is incredibly important. The most sustainable projects actually have multiple funding streams. So obviously right now we're kind of relying mostly on one source, although you do have partners that are at the table kind of through in-kind sometimes right now even that are part of it. But where can you tee up new funding sources, even right now? What about moving kind of the next phase of this project into your Flex grant, your normal Flex grant? Or is there an entity in your state or in your region that funds rural EMS or ambulance services that might be interested? Or is there community-based funding? Oftentimes there are foundations that were created by some benefactor that has an interest in rural or a particular condition. And so they might be interested in funding something like what you've done through the success you can demonstrate. Let's see, informing organizational and structural changes is another important strategy for sustainability. And that's really using the evaluation and the things you've been monitoring and describing all along here. So using those evaluation findings to inform the decision where program elements either should continue and how they should be provided and by whom. Again, it's kind of that proof of success. And then can you use the data to either confirm or adjust organizational or structural needs? Maybe there's a more scaled down version of your project that's actually more applicable for the future and more appropriate. Or could the responsibilities, kind of thinking about a structural change or organizational change too, be distributed broader or differently or to others? Can the program just completely be shifted to another organization or a bureau to lead or expand? And lastly, kind of telling your story. And I know that FORHP and the Flex monitoring team and TASC have been, trying to support you in this all along and in the regular Flex grant work too, but developing an effective message about the work that you're doing is also incredibly important. So that has that lasting impact. That's that document that we can all see. There's, being able to tell our oral story but being able to share the data and share that written story is really important too. So what tools or resources, short stories, we've been using some videos in some cases, and some really made pretty low tech and inexpensive. Case studies, even social media messages that can have this big impact to tell your story about what's happening with your project. So there's some strategies there that you can use. We can send out this slide deck because the links are all in there and some things that you might want to utilize in the future for thinking about sustainability. So with that, we wanted to ask a couple questions about, and we're going to put 2 polling questions up, kind of just to get a little bit of a lay of the land. So the first question is, based on where your project's progress is here at the end of year 2, what % of your project do you think today is sustainable if the funding ceased? So obviously the funding's not going to end, but if it did stop today, what % of your project do you think is sustainable in the future? So that's the first question up there. And then your second question is, based on where you think your project will be at the end of year 3, when the funding really does stop, what % of your project do you think will be sustainable then? Again, we can't tell who's saying what, so nobody's going to be like, oh, they said that's not going to be sustainable. That's okay. We want to be realistic. What % of it do you think could happen? Either now if it stopped or next year when it truly does end. Okay. And I don't know, Andy, if we're broadcasting the results that everybody can see. Okay, so maybe once we get.
Yeah, it looks like we're just waiting on maybe 1 or 2 more.
Okay. Thank you.
All right, I'll go ahead and pull them up now.
Okay, thanks. So it looks like right now, like if we pretended that our projects were ending here at the end of next month, about, I guess, a little bit more, the majority of you think that 50 to 75% of your projects would be sustainable. So that's pretty cool. You're not even complete yet. And you think that, you know, there's a good chunk of your work that would be sustainable. And 2 of you are saying that you think, you know, either 3/4 or almost 100% of your project would be sustainable now. And if we look at the results for what we really anticipate to happen by the end of next year, most of you are saying that you think that either above 51% to 100% of your project is sustainable. So that's really exciting. And hopefully the next kind of part of the conversation here will provide a little bit of good food for thought about what to do to make your project even more sustainable in the future. So what I'm going to do is give you some instructions. We're going to move back into the mural space. So you were asked kind of in advance with the email that Nicole sent out to kind of come prepared to be able to share your short-term, intermediate, and long-term outcomes. So I'll show you the space in mural that we'd like everybody to hop back into to do that. And, so hopefully you're seeing mural here okay. And the layout's all still the same, so you know you can go to whatever state your name here is in the outline. If your outline has happened to go away, again, it's this set of like kind of bulleted dots here in the corner. You can click on that and then see, you know, which place you want to go to. But when you get to your place, and I'll just do this for the sake of it, say I'm Kentucky, I want to go and I'm going to work on filling in these 3 boxes right here. So what we want you to do is to paste your outcome metrics into these boxes, your short-term, intermediate, and long-term. So again, you can double click to get a giant Post-it note, which you can always resize as needed, and go ahead and put in your outcome metrics in there. So we're going to give you maybe 5 minutes to do this. Hopefully you guys have these all handy and you can just copy and paste them right in there. We'll come and support you as needed. And if you're kind of running out of time, we can always shoot people back into the breakout rooms as needed. And yeah, any questions about that at all?
Don't be confused when, like, if you're Washington and you click on Washington, you fly to your space, and then you notice that the ear has another state listed next to it. Disregard that. Don't worry about that for right now. That's in our next step, just so you don't get confused.
Okay. So Andy's going to shoot us into our mural spaces and into our breakout rooms again. Again, and just put in your short-term, intermediate, and long-term outcomes. If you're all done real quick and you want to just hop back into this space and leave the breakout room, that's great. And then we'll move on from there. Thank you.
All right, sounds good. Tracy, did you say 5 minutes?
I think that would be good. I'm hoping everybody, I don't know, can we get a thumbs up from those of you who have a camera? If you're ready and prepared and you have your outcome metrics, the quicker we can move through this part, the better we'll be. Okay, see a couple people nodding and the rest of you, I'm just guessing. So we'll go with 5, Andy, and we'll go back if we need to.
Sounds good. I'll open those now. Thanks, everyone.
Into mural. So what we're going to do now is get you to think about kind of evaluating somebody else's content with the hope that that provides them a little bit of good feedback, but also maybe allows you to do a little kind of self-thought about what you could do to better tell your story too. So I'll tell you what we're going to do, and then I'm going to ask John Gale to maybe provide a couple comments before we move into the breakout rooms. So we're going to pair you up, and you'll have an assignment, and you'll go back into the mural space. And what we're going to ask you to do is look at another state's content that they've written down. And we want you to pretend that you're the funder. So say, let's pretend here for a second that Nicole was representing XYZ state, and I'm just pretending right now that I'm the funder. So I would go look at Nicole's outcomes that she wrote down that she's hoping to get to it from the project. And we heard today what everybody's working on. We've heard what your activities are. We've heard about your successes. And there's a box next to Nicole's XYZ state. And I'm going to look at that and pretend that I'm the funder and think about what are the things that I would want to learn from her or know more about that I felt confident then as a funder continuing to fund her project for sustainability. So we're kind of pretending here, but we're pretending that the tables are turned, that we are funding somebody else's project, and you're reviewing that state's outcomes and the story they've described to you today so far. And we just want you to think about what other evidence you'd want to see from them to convince you to fund their project. So I'll repeat that instruction again in a little bit. We'll tell you who the pairs are. But John or Sarah, before we move into the breakouts, any kind of words of wisdom from you from the evaluation standpoint about things that you think funders, be it the federal office or other funders like we talked about for sustainability, find really valuable when they're evaluating a project and thinking about if they have the evidence there to consider funding it?
John, are you going to be responding to this one?
Maybe he had to step away.
I'm
totally putting you on the spot.
Yeah,
here.
I feel like I am being put on the spot a little. I'm sorry.
That's okay. I think that some of those strategies that I shared earlier from the documents from RHI Hub and things like that are good to consider multiple funding streams. I think it's always really nice too that when you're applying for a funder that you have kind of teed up in your mind where that next source is coming from, who's going to own it later on. One of the projects that we've been developing as an organization right now, we're actually going to be seeking funding for, but the communities that would be supported by that are actually going to have an in-kind contribution to it, or not in kind, they will be paying into being part of the project too. It's not just kind of wholly given to them. So that's just an aspect about funding, but I think there's other multiple ways to kind of think about sustainability too when you go into just being able to tell your story well, or are your outcomes actually measuring an appropriate mode of change and meeting really a community need. So we know that besides, John, maybe the rest of us aren't experts in this, but what we want you to do is hop back into the mural space, and we'll give you their assignments here. I know Nicole pasted in the chat as well, but kind of the question that's in chat, the tables are turned, and we just want you to hop into someone else's mural space, and we'll tell you which state you had, and we just want to look at what they have documented there, and you'll see a little gray note taker space, and just type into there, what are some other things you'd want to hear from them, some other evidence you'd want to see from them about their project and the anticipated outcomes so that you would feel comfortable funding them if you had money to fund them with. Any questions about that? Okay, so we'll hop into that chat as well.
Was it the task? Sorry, was it the task use box? The notes of suggestion? Is that where we're writing?
No. Yeah, I'll show you here in just a second. I'll show you exactly where to go in mural, but I'm gonna put.
I'll put the state pairings in the chat.
In there. Okay, then I'm gonna share my screen quick. So
you got it.
Back in the mural space here. I don't even know which state I'm on here, but we'll look at that. So let's pretend, that we go to Ohio. Oh, that was where we was with Daniel. So if you can see here, South Carolina is going to be assigned to Ohio. We'll put that in the chat. This is the little gray box right here that we want you to use. Is as a funder, what more information do you need to know from this state? And we want you to pay attention to these outcomes that are over here that Danielle typed in for Ohio. What other things do you need to know from him so that you can feel, oh my goodness, like you can tell that story to that state? We'll get those moved back. So Nicole's going to drop into chat who those states pairs are. And I want to make sure we don't have any questions. This is kind of one of the last mural. This is the last mural piece we'll do for today.
Yeah,
anybody have any
did
questions?
it. Yeah,
okay.
He did it. So basically, you can see it says Florida / North Dakota. So you guys will do each other's. So Florida, when you get in there, you can go to North Dakota space and look at their outcomes and then use the little gray box right there to add your suggestions. And then vice versa as far as the pairs go. So Florida go to North Dakota go to Florida, New Mexico go to Kentucky go to New Mexico. Is that making sense for everybody? I see a thumbs up. Okay, if not, speak up before we fly you all off into cyberspace. We'll pop into rooms too, of course, but
Sounds good. I can go ahead and open those rooms. Tracy, Nicole, how long are you thinking for this?
I think just 5 minutes is probably sufficient. Just type in a couple notes and thoughts, and we can follow up with this as a further activity if it's helpful.
All right, sounds good. I'll open those now. Thanks, everyone.
Andy, excellent, great. Well, thanks for doing that. I recognized too that we hadn't teed you up beforehand today to say, oh, you're going to be telling a story to a pretend funder. That was actually intentional. So we realized that the way you were sharing your thoughts before and things like that were more in casual conversation with one another, but it is an exercise in storytelling. So hopefully you had a chance there to provide some thoughts or feedback to a peer about what it is that you as a pretend funder would like to hear more about from them so that you could pretend to fund their project. But we also will, I think, within the TASC team, and we'll work with the Flex monitoring team too, and go back into that mural space and make sure that everybody has some feedback from our TA perspective too about what it is that we think could benefit you as well if we were the pretend funders too. So we'll go back into that space. But I wanted to kind of close out our conversation here today, thinking about sustainability, and then I'll transition things back over to Nicole to kind of end our day. But when you think about the things that have been shared so far today around the word sustainability and the different strategies that can be utilized and what a successful sustainable model looks like, I'd like to hear from each person. I'll go through the list of names here about a word or a phrase that jumps out to you when you think about sustainability. So I'm going to pull up the participant list and kind of start at the top of my list. But Caleb, you're first on my list. So what's a word or a phrase that kind of jumps out to you when you think about the concept of sustainability?
Commitment. Whoever's working with it has to be committed to the process, so commitment.
Great. Okay. Donnie, how about you?
Take me a minute to unmute.
Okay.
I like commitment, but also I'm trying to think of the word for it. Somebody that come back to me. Let me think of the word real quick.
Okay, I can do that. Sure. Joyce, what's a word that jumps out to you?
I guess partnership, because, you know, you're going after these funds. You should have a relationship with these people, have them know who you are. So that partnership building is core to anything you want to do, especially on sustainability.
Yes. Lindsay, is there a word that jumps out to you or stands out to you?
I guess resources is something that kind of stands out to me with sustainability.
Okay. Martina.
I would say improvement.
Improvement.
Just to make things better to work on.
And John, what word comes to your mind when you think about sustainability? John Gale, how about you?
Yes. Continuity.
Continuity. Okay. And John Noakes, what about you?
Oh, sorry.
Nope, there's two Johns. That's okay.
All right. I kind of go back and forth on this one, and I think they're really the same thing, but either not necessarily a visionary, but somebody with a vision, or a cheerleader, someone to champion what you're trying to sustain and why.
Okay. Mike?
You already said it, but making it better.
Making it better. Yeah. Let's see. How about Sarah?
I would also say partnership, that the most sustainable initiatives I've seen really have established a good basis of collaboration with other organizations, and that's really essential for keeping something moving forward.
Mm-hmm. Tahleah, is there a word that comes to your mind?
You know, I wasn't thinking of a word myself. I've just been sitting here listening to everyone else say all of their words, but you know, for sustainability, yeah, I really like commitment. I think it encompasses sort of some of the other words as well, like partnerships. I think if you're committed, then you will also sustain some of those partnerships and be able to get those resources and some of the other phrases and words that others have said.
Yeah. Thank you. Abby, is there a word that comes to your mind when you think about sustainability?
Yeah, I actually completely agree with Tahleah. That's kind of what I was thinking too. I was toying between like commitment, partnerships, but I feel like commitment does kind of encompass sort of everything that, yeah.
Okay. Britton?
I'd say buy-in. It's getting the buy-in of both the internal and external partners to believe in your mission, vision, and the process you're using.
Mm-hmm. Crystal, what about you?
Yeah, everybody had great words. I guess optimizing resources.
Okay, optimizing resources. Kayla?
Juan and I have picked the word worth. If it's something that partners are coming together to do, then it's something that's worthwhile, and worth or worthy would be our word.
Okay, great. And Donnie, back to you one more time.
So responsibility, once this is done, people need to take responsibility for their people and everything else to assure that things continue to operate.
Mm-hmm. Great. So kind of a question to everybody, and chime in as you will, but what kind of questions come to mind when you think about, what questions do you have about project sustainability? What are some things you're wondering about now that we've been talking about it here for a bit?
Well, I work for an EMS association, so they're like, maybe this is something that EMS agencies would pay for, to have kind of someone working with them and stuff. And I think that's a hard sell for especially volunteer agencies, to pay someone to help them with their data. But so sustainability is another grant or something like that to continue on for the pieces that we need to continue on.
Sure.
Just gonna kind of echo what Lindsay was just saying is one of the things I found with the engagement I've had with our groups is they know they need to do something. They know there's something that can be done, but they don't necessarily even have the resources to know what those things are. And through our subject matter experts and through leadership classes, and even just going through the 18 attributes, we've put together action plans for our agencies, but looking at from the bigger picture is your agency is doing all these things or should be doing all these things anyways. And at some point, instead of just trying to focus on the attributes, do your day-to-day operations. And when you have a question about budgets or you have a question about equipment or data reporting, then you go, there's a resource for me. I can at least start there. They have a better understanding of where they might find some help, or a better understanding of how to actually attack that problem or to manage that problem.
Yeah, absolutely. Great. Well, and I guess kind of a last question before I turn things back over to Nicole to kind of wrap up today, but what are some things that are coming to your mind as you're thinking about your project sustainability? What are some options that maybe you are starting to think about for project sustainability for this particular work?
For us, everything's recorded. The reports are available. The toolkits will be there for forevermore. So, I mean, there's pieces of it that will be, I guess, already in my mind is NEMSIS version 3.5, which then would be some, someone would have to pay for some changes to the reports and stuff. So getting that in the mind of the state or different people, but those are things that I've been doing to try to create some permanency.
Yeah, so some documentation and some maybe getting the feelers out there for the next iteration. That's good. What else? What are some other options for your projects for sustainability?
Well, one thing might be sustainability is maybe we do the groundwork and get it started and maybe somebody else picks it up and keeps it moving forward. So I think we kind of internalize it, but it could be pass it on to somebody else to keep it going.
Yeah, yeah, yeah. And you guys are definitely with the NQF work too. There's lots of other people aware of that work then. So that's valuable, as well as having the people to pass it to, in the future. And
Right.
Joyce, I see your comment too about keeping the momentum on the value of telemedicine. Absolutely. Yeah.
Yeah, I mean, that's going to be key, right? I mean, especially with this pandemic, and if there's a time to keep and push for sustainability on what has happened and what can be, what can continue to happen in the value of it is so necessary. And so, building on that, but
yeah, interestingly, I was just looking at an article this morning in JAMA that was about COVID-19 and utilization differences, not within EMS, but between organizations that were in a risk model for value-based payment, or compared to those that are still in fee-for-service. And the ones that were in a risk model were more likely to utilize and adopt and use telehealth visits, but not necessarily because of the payment mechanism, but because of their emphasis organizationally on quality and value and risk because of it. So kind of interesting, and just kind of proves the point of the transition to value within the healthcare system. And of course that encompasses EMS as a critical role within that too. So, okay.
I think that's one of the areas I struggle with our project is for sustainability, is because we're not necessarily saving money or here or shifting fees to here. And, at the end of the project, we saved 5% or 10% or whatever percent that can be rolled back in. Where a lot of ours is we've created materials, we've created tools for these agencies to use. And so they can get in people to actually help respond. So it's not burnout, they're giving better patient care, but there's not actually a return on the dollar for that. So how do you sustain that without external funding?
Yeah, yeah. And there might be methods too to think about, kind of like for the next iteration, if there was interest. We use metrics that are about not necessarily ROI in our program, but we use them on return on community investment. So saying, what's the community-based impact because of this, not just the organizational-based impact. But it takes kind of some established programming, which is what you're doing right now. So yeah, great. Well, I hope this just kind of like gets you thinking a little bit about sustainability. As this project enters year 3, that's what much more of the focus will become, is like helping you as best possible to achieve the outcomes you've set up to desire, or set up to create impact on, and continue to navigate the ever-changing world that's probably changing more than we all want to right now. And just, set your project up for documented success, and then what could be next within it. So this will be a project or a topic, sustainability will be a topic kind of more in the future here as well. So with that, I will kick it back over to you, Nicole, to wrap up today.
Yeah, so super quick, and then I just have some announcements, but just super quick, one thing that you are taking away from this meeting today, and I'll just call you out. Let's start with Abby in Florida.
Sorry, couldn't figure out how to unmute myself. I think one thing that we're taking away from this meeting today is I think we want to evaluate our outcome measures a little bit more, as we were coming up with them and then looking at the other states. I think, that's something that we could look at a little bit more and improve.
Sure. What about you, Mike?
Well, it's nice to have the conversation about sustainability, because I've been thinking about that. How can we keep it going? And it just helps to start the juices thinking in that direction. So that's been helpful.
Good. Joyce?
I just, about the breadth of the projects, hearing about the projects again, I think is really, really valuable. And it seems that, like even the state of Arizona, we're working on a variety of things that I think the results of what each of these pilot sites are doing, how we can pull and utilize it within our state in other venues and other approaches. So I'm really looking forward to, these final reports and being able to see, with the toolkits and all of that. I think there'll be a lot more that others can use the information. So.
Great.
Yeah.
Britton, what about you?
I'll join in on sustainability as well. It's so easy to fall into thinking of just the financial sustainability of a project, and good to step back and think about all the other factors that it really takes to keep something going in the long run.
Mm-hmm. Yeah. Caleb?
For me, adaptability, just being able to, even though we had the bad setbacks of COVID, just being able to adapt our project and be able to still keep it successful. That's the biggest thing for me.
Mm-hmm. Crystal in New Mexico?
Sure, I think I'm going to go with the sustainability as well. I mean, just to being able to figure out how to continue it. I know Donnie does an excellent job here in New Mexico, and I know he'll, figure out ways to do it. So I believe in Donnie kind of a campaign. But yeah, absolutely. Any way that we can help Donnie with that, we're all for it.
Okay. Just for the sake of time, does anybody else have anything they want to throw out there? All right, I am going to go ahead and venture an educated guess as I'm thinking about what goes on in our last program year that we'll continue to talk about sustainability. I think what we did here today was just kind of an introduction to, hey, let's think about it, and we'll definitely be talking about it more going into the next program year. So with that, I have just a few things to throw out there to wrap it up. Andy is going to launch some post-event polling questions. So Andy, you can go ahead and put those up now while I keep on talking. Just a couple of things. Recently released the Implementing and Sustaining Rural Community Paramedicine Guide. There's a link to that in the chat. Know that too, that there was a webinar to launch that to the Flex programs, and that is also on that page if you're interested in watching it yourself, or we would definitely encourage you to share that resource out with your rural agencies or anybody else you think might be interested in it. Also, right around the same time, the Community Paramedicine Impact Reference Guide was updated. This is a document that we originally released last summer, but now it's been updated to include cited publications about community paramedicine projects through May of 2021. So that's been updated, and that link is also in the chat. And for fiscal year 2020's TASC support, we have one activity left, and that is the second RAP interview, or Recommendation Adoption Progress interview. Those will be happening in August, and I'll be reaching out to you to get them scheduled. And then really that's just a half-hour conversation, so that should be pretty easy as far as wrapping up our activities for FY20 as far as meetings, webinars, and education and such. But do know too that, as always, we're here to support you in pretty much any way you need: questions, contacts, resources, etc. And also just a reminder that subject matter expert calls are available to you. So we support having a consultant on whatever topic you need talk to you for an hour and answer your questions about whatever it is. So not anything like we can't talk about astrology, but topics that might keep your project moving along and get the work done. So just reach out to me if you're interested in that. We can talk more about it. And then that's it. We'll be communicating more soon about what FY21's activities look like, and FY21 is the next program year, and that starts September 1st of this year. So that's it, unless you guys have anything else you want to add or ask.
Thank you.
Yeah, thanks. You all have a good day. Bye.
Thank you.
Yeah.